Okay, good morning. I'm Jane Finley. I'm a pediatrician here at BC Children's Hospital, and I've done a fellowship in infectious disease, and I've worked on the Canadian Pediatric Society Infectious Disease and Immunization Committee. So sometimes people call me the shot doctor, because just we have to do disclosures. So funding for this program is being graciously given through an unrestricted grant from Merck, so thank you very much. And I personally have received lecture fees from Novartis and Pfizer. So this vaccine program has just been mired in controversy since its inception. It was brought into the school system here in September 2008, and there's been a heck of a lot of resistance generally and from faith-based groups. And then in 2012, we had the recommendation for vaccination of males as well. But we know that the uptake is disappointingly low. This headline was in recent Vancouver Sun showing that only 2/3 of girls in grade 6 are getting their vaccines, especially in the Fraser Valley. Some religious schools, it's even lower. And overall, by the age of 18 across Canada, there is some catch-up, but it's only 70%. And this vaccine equals MMR in its depths of controversy of whether parents choose to get this vaccine for their children. And you really have to wonder why. Because I tell people, my gosh, this is a vaccine for cancer. And if this was a vaccine for breast cancer, the girls would be lined up down the hallway, right? But I think it's the ick factor, to tell you the truth. Many people feel that, well, their child isn't going to get the disease, and I usually tell people, even in a traditional culture, your daughter will likely be a virgin, but maybe her husband won't, right? You've got a 50-50 chance of getting it from him. They're worried that giving the vaccine will be a license to go out there and have sex, but I think that's kind of like not letting teens wear seatbelts. You know, if we wear seatbelts, then you won't drive too fast. You know, I think that people don't understand why we're giving it in grade 6, and I think that we could have more education on that point, that, you know, it's stronger, it works better, you only need 2 doses. And also there's a conspiracy theory of Big Pharma, and this was even in the Canadian Medical Association. Remember that we were all in league with Merck, and our girls were being guinea pigs. So great news that BC has extended the funded program to at-risk males, but I personally think it's not enough, and certainly the BC Pediatric Society strongly recommends the universal program for girls and boys. It's interesting that this free program extends to gay men, gay boys, but also those in foster care, street involved, and those boys who are questioning their sexual identity. So I think there's a lot of leeway here. I've told my son he's going to be gay for the day, and you know, who knows? And you can order this vaccine into your office, so they don't have to go line up at the public health clinic. I'm a bit concerned that you're supposed to identify them, and maybe some boys might not want to be on the list. I don't know, but there it is. So you can order it into your office. So.
That includes HIV patients?
Yes, oh, definitely. Well, they are funded, right? Yeah.
But it's also age restricted.
Yeah.
Well, we're going to down. It's up to age 26.
Yeah, up to age 26, but yeah. But this will be part of the program. So we have an amazing list of speakers today. We're really going to cover HPV from top to bottom and the impact of this vaccine. And our first speaker is Diane Miller. So Diane Miller is the Division Head of Gynecological Oncology, Provincial Gynecological Tumor Group Chair at BC Cancer. Dr. Miller's divided her training between UBC and Toronto, and actually worked as a family doctor. I found this really interesting, in Yellowknife, Northwest Territories. Dr. Miller is actively involved in both clinical trials and collaborations with translational and basic scientists. And her particular interest is looking for potential screens for early diagnosis and in targeted therapies. So if we could welcome Dr. Miller, please.
Thank you. I think everybody should do a couple of years of family practice before becoming a specialist. It certainly helped me. Great. It's nice to have somebody do this. Okay, I'm at the reading glasses stage, so I'm not really sure if I will be able to see my slides. So if I have to put on the reading glasses, I apologize. So I'm going to start at the bottom, HPV from top to bottom, and I'm going to start at the gender bottom. I'm going to start with adult women and HPV infection in adult women. Okay, why am I not advancing the slide? Not with the mouse?
You can just use.
Oh, just with these ones. Okay, great. So I've participated as an investigator in clinical trials for GSK and Merck. I've also received speaker fees from both Merck and GSK. And I didn't put here that I'm on an advisory board for AstraZeneca, which is not relevant to HPV. So my objectives are to describe the burden of HPV-related disease in adult women and to cite some of the evidence for the benefits of HPV vaccination in adult women, and also to discuss some data supporting the 9-valent vaccine and provide some recommendations related to HPV vaccination. I had to go through my talk last night, and as I looked through the agenda for the meeting today, I knocked out all the boy slides, I knocked out all the screening slides, I knocked out all of the head and neck slides and everything. So I'm going to restrict myself predominantly to the gynecological implications. I think the first thing we need to know, and we know this from a cancer standpoint, is HPV is everywhere. And probably everybody recognizes Michael Douglas from his disclosures a couple of years ago. Looking around the room, probably some people weren't around when Farrah Fawcett was around, but she also was very public about anal cancer, which is another HPV-related disease. Oh, sorry, that's his throat. Usually I get to give my talk just before lunch, so I get to show the gross pictures. And these pictures, this is a vulvar cancer, a very sad story of a vulvar cancer, a woman in her 40s who actually was a nurse, and she thought she had condyloma, and she was so embarrassed about having condyloma that she actually didn't seek medical care until she was admitted to her local hospital for depression, and the family doctor that went in to examine her noticed a very peculiar odor, and she disclosed that she had this lesion on her vulva. Suffice it to say, she ultimately died of her vulvar cancer. Here's a cervical cancer. We do see about 140 cases of invasive cervical cancer in British Columbia every year, and a third of them will die of their cancer because it's diagnosed at an advanced stage. And this is more usual what we see for vulvar cancer. I'm not going to go through head and neck, and certainly as a gynecologist, not penile cancers. One of the things I would like to comment about anal cancer, though, is me as a GYN oncologist, I always thought anal cancer was more common in men than it was in women, because there's so much publicity out there about men who have sex with men and the risk of anal cancer. But in actual fact, more than half of the anal cancers are in women. So it's and you'll hear about that, I'm sure, in one of the later talks. So what about HPV infection? Well, as I said, it's everywhere. And it comes in two varieties. It comes in the high-risk HPV, and it comes in the low-risk HPV. And HPV is responsible for the development of cancer precursors at many sites, and we're going to hear a lot about this today. But low-risk HPV, as you're probably going to hear about, also is not a problem. I'm forever telling my patients in the colposcopy clinic that nobody ever died of warts. They just think they're going to die of warts, right? And it's interesting from a gynecological perspective how much more upset women get about having genital condyloma than they do about having an abnormal pap smear and CIN, where the CIN is the one that's going to kill you, not the warts. But culturally, people get very disturbed about having condyloma, so we shouldn't forget that. So what's the burden of HPV in Canada? Well, in the country, we get about 450 deaths from cervical cancer, and as I said, in our province, we get somewhere between 40 and 50, our usual 10%. There's a lot of cervical cancers that get treated, and it's pretty consistent that 1 in 3 will die when they get invasive cancer. Genital warts, lots of cases of genital warts. And CIN, most GYN oncologists and many gynecologists make a good living treating CIN. What about British Columbia? Well, every year there's about 600,000 pap smears done, and I'm not going to go through the screening recommendations because Gina's going to talk about that later. About 1/10 of them are abnormal, so 60,000 women will have abnormal pap smears. Most of the time that will just result in them being asked back to have another pap smear in 6 months because most of them are nothing. But about 7,000 of them will be referred for colposcopy each year in British Columbia. And of those women referred for colposcopy, almost 1,500 of them will have a treatment done to their cervix. Most of the time, the treatment involves removing the epithelium of the cervix with a treatment called LEAP, or it could be laser. We've actually stopped using cryotherapy in British Columbia because it interferes with the ability to do pap smears in the future. And we did see that even though it's an effective treatment, it's hard if they recur to diagnose. So does it cost us anything? Well, there was an analysis done at BCCA several years ago, now 10 years ago, and at that time it was estimated that HPV was costing $37.4 million, and I doubt that it's actually decreased in cost since that time, but the bulk of the money we spend on HPV is on the cervical cancer screening program. And that's just shown in this pie diagram, is that looking at cervical cancer, obviously there's only 140 cervical cancers, but the money that we spend to prevent those cancers is tremendous. And then the second biggest bar is the condyloma, which is the non-malignant disease. So this is a slide from Quebec, and this slide just shows you that proportionally the cancers that are caused by 16, 18, and as you know, the 3 available viruses all cover 16 and 18, and that accounts for the vast majority. Just talking about the 9-valent vaccine for each of the sites, you can see that you get a bump up in terms of the ability to prevent more lesions, and being a gynecologist, focus mostly on the cervix and the vulva and the vagina, of course, but the cervix, which is the major area of focus, and you get quite a significant bump from about 70% protection to about 90% protection. So just a little bit about genital warts. The vast majority of genital warts are caused by type 6 and 11. And in fact, if you look at the Australian data, somebody came out and said maybe they're all caused by 6 and 11, because they basically, you'll see from a couple slides that I'm going to show you next, that they basically had a disappearance of genital warts secondary to their wide coverage of vaccination with the quadrivalent vaccine. Sorry, this seems to have done something. I just wanted to, from a cancer standpoint, because I know you're family docs and pediatricians, but from a cancer standpoint, I think we should not underestimate internationally the importance of HPV in the genesis of cancer. And it's estimated that almost a quarter of all cancers worldwide are HPV related, and that's because even though we only get 140 cervical cancers, the rest of the world is not so lucky because they don't have screening in that, and almost 250,000 women will die of cervical cancer every year. So we're sitting in a room here in a developed country talking about vaccination and that, but I think we all have a responsibility to lobby our various governments and that, really make sure that this incredible preventative strategy actually reaches the people who are at most risk. So I just also want to, one of the things that I get asked all the time is, should, obviously I'm in a stable relationship, blah, 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 blah. I always say to women, I don't know what you're doing and I don't know what your husband's doing, and I don't have the tools to figure that out, right? But what I do know is that people do still acquire HPV, new strains, as they go on later in life. And there may be many reasons for that. Marriages break up, new partnerships, etc. So we're not immune to picking up HPV just because we've been around for a long time. And we do see this bimodal distribution. The available vaccines right now are the bivalent vaccine that covers 16, 18, the quadrivalent, which is the one still being used in the schools. I'm not the expert. The 9-valent vaccine is new to the game, and that's the one that I think we're probably focusing on today. And certainly, I think from an oncological standpoint, the one that I personally am most excited about. This bar graph here just shows you that type 16 is by far and away the most important contributor to cervical cancer, followed relatively closely by 18. And then each of the other subtypes incrementally contributes less, but when you add the next 5 most relevant ones, you get up to a bump of about 90% coverage, which is pretty good. And from an oncological standpoint, and I'm not the screening expert, but I think you should ask Gina, is there a point of vaccine coverage where screening will become irrelevant? Because I think if we got 100% coverage of our population and we prevent 90% of the HPV-related diseases, then the cost of pap smear screening by far outweighs any of the individual or any of the cases that we're going to get. And it may be in the future that we will be looking at different algorithms for screening. You know, recent immigrants might have a different algorithm than somebody that's been through the school program, that's been vaccinated. I think one of the tragedies here is it's very difficult for the vaccination programs to actually talk to the screening program. Manitoba has done it well, but I think British Columbia is way behind in terms of allowing those registries to talk. So I think I already said this. I don't know why the 9-valent bar is bent, but maybe that's a good thing. Just to go over again, for cervical cancer, 70% is covered by the quadrivalent and the bivalent vaccine via their 1618. If you look at CIN 2 and 3, I did show you that we're doing over 7,000 colposcopies a year in the province. We could cut that in half by having a good vaccination cohort. So that would make for a lot less colposcopies that need to be done in the future, and then obviously a lot less treatments. Just a little bit about cancer of the vagina and cancer. Cancer of the vagina, incidentally, is very rare, and most of the cancers of the vagina are actually cervical cancers where the woman's had a hysterectomy, but there's still a dysplasia at the top of the vagina. She doesn't have a cervix, so it's a vaginal cancer. And that can progress to cancer, or cancers of the vulva where they're encroaching on the introitus and lower vagina. So the vagina, the mid-vagina is actually a very, very rare site to get cancer. So the vagina per se, most of them are probably just spillovers from the organs on the top and bottom. Vulvar cancer, second to cervical cancer, is the second most common HPV-related cancer that we see in gynecology, but even it is not all that common. But what I would like to point, and vulvar cancer, not all of them are related to HPV. About a third of them are related to chronic irritation associated with lichen sclerosis, P53 mutations, etc. And they're quite different. They look different to the pathologist. They don't have the VIN precursor lesion that we see. And so there are vulvar cancers that are not HPV related, and I believe that probably also holds for some of the other sites. But certainly cervix, it's, I think, 99.97% of cervix cancers are related to HPV. The majority of vulvar cancers are related to HPV, and the vaginal cancers, from what I've talked about before, being spillover from cervix and vagina, are also HPV related. If we look at the nonavalent vaccine, and we were very lucky in Vancouver. I think between BC Women's and VGH, we had over 400 16, it should say 16 to 20, or well, I know it's 6 to 26, but the trial was 16 to 26 years old. And we had over 400 women enrolled in that trial. And really very, very good compliance with it. But what we do know is that at the end of the day, the efficacy of the nonavalent for the non-16, 18, 6, 11 subtypes was pretty much as good as we saw with the original quadrivalent vaccine. So I think we have very high hopes that it will perform in the long run as well as it will in the, or as it did in the study. And the same actually holds for the vulvar vaginal and persistent infection, very similar to the results that were there for the quadrivalent vaccine when it came out, and bivalent vaccine. How we know it works? Well, I think, all of us who are in the oncological world felt that the first thing that was going to happen is we'd see a fall off in genital warts, because we see genital warts in our clinic generally fairly closely after sexual debut, and most of the genital warts, and I argue with the Merck people who come to my office all the time and tell me genital warts are important in the 30s and 40s. The reality is women who get genital warts in their 30s and 40s usually get one wart or something. The late teens and early 20s can get florid condyloma, and that's where we see the people that are incredibly distressed by venereal warts. So our prediction is that when we started to see young women or girls being vaccinated, that the first thing we would see would be a fall off in genital warts. Fortunately, Australia started their vaccine program before us, so they actually were able to confirm that. And they had a virtual disappearance of condyloma in the vaccinated under 21 women. And I think also it's interesting, they had a fall off in the unvaccinated, which is sort of the first clue that there might be a little bit of herd stuff going on. And this is, again, Australian data, and this is just looking at the number of people who required treatment for genital warts. And as I had said before, the late teens to early 20s was the group that we really see. And prior to vaccination, you can see that that's the group that required all of the treatments for condyloma, and it fell off precipitously after vaccination. So there's been a virtual disappearance of all genital warts. And as I said, some of the folks in Australia say, well, are they all 6 and 11 then? Because certainly that's not what we believe, that we believe there's other low-risk types that do contribute, probably about 10% of them. But there's definitely a herd effect for both heterosexual men and possibly unvaccinated women. There was no protection in Australia for men who have sex with men. And I think that was the first sign that maybe this is going to work for CIN, which is really what we want it to work for. And I'm not going to go through this because Gina's coming and it's her data. So Gina Ogilvy actually looked at an ecological analysis of what's happening to CIN2+ in British Columbia. And she'll go through this in more detail. But basically, they took women who were 16 years old at different times, and there's been a fall off in the rate of CIN2+, which are the high-risk lesions on the cervix. Now, I would just like to put a little plug in here. This is a really interesting study, but we sure don't recommend doing pap smears on 16-year-olds. We recommend that you don't start till age 21, and it's the bane of our existence when we see a 17-year-old referred to the clinic with an abnormal pap smear, because almost inevitably these will disappear. I don't believe in my career, which is now encroaching on 25 years, that we've had a 20-year-old that's had an invasive cancer of the cervix. So what we don't want to be doing is medicalizing and traumatizing young girls by doing pap smears, even if they're sexually active, to prevent something that's not going to happen. So I'm very much supportive of we're actually even thinking of starting the program at 24, and I'm not, as I said, I'm not going to get into that. But right now, the recommendation is for age 21, and certainly encourage people to do that. Gina would never have had this data if everybody didn't disobey that. But maybe we'll have to do an Ontario thing. Ontario has implemented, if people are being screened more than the recommendation, they just throw the smear out. So they're not willing to they have a 2-year program, and they're not willing to screen people every year who do not need to be screened every year. It's a huge cost. I want to just have you have a peek at this slide, because this is where it's important to me. I do a lot of work in the colposcopy clinic. So we treat women for cervical intraepithelial neoplasia, vulvar intraepithelial neoplasia, and some in the vagina. And what I thought was really interesting is because the vaccine is actually a prophylactic vaccine. It's a preventative vaccine. It is not a therapeutic vaccine. We know that it doesn't treat pre-existing disease, but we do know that a not insignificant number of women, somewhere around the 10 to 15% of women, after we treat their VIN or their CIN, will have a persistence of their HPV infection. And those women remain at increased risk for the rest of their life of getting HPV-related disease and invasive cervical cancer. And I'm sorry I don't have a slide, but we actually did a study looking at women who had been treated for CIN3 in the province, and I believe they have a 4-fold increase in their risk of getting invasive cancer in the future, even though they've been successfully treated for that. Though that's because of persistence of the HPV infection. So what we do know is that there is evidence from the Future 1, Future 2 studies on the quadrivalent vaccine looking at the persistence in those women who were on the trial who usually had been, because they weren't screened for being HPV negative at the beginning, who were treated, and there's a decrease in the persistence. We're lobbying to try and get this group of women covered for vaccine under the age of 45, because I think this is another area where we can make an impact. And it's not a huge number of cases, it's not a huge public health cost, but if we can decrease the persistence of HPV, we provide a real benefit in preventing invasive cancer. So this is actually quite an important thing. So what do we know about the vaccine? Well, it's best given before sexual debut. The school program, probably, I'm not going to go through that because there's a lot more experts than me. So far, no booster is necessary, and there's over 10 years of follow-up. Older women do require 3 doses, and I think it's really important to emphasize that if you are vaccinating older women. It does appear to work, and it appears to decrease the risk of viral persistence, which you don't hear a lot about. Yes?
Is there an age cutoff at all anymore?
Well, we follow the NACI guidelines. So if somebody comes into my clinic and they're 70, I don't recommend an HPV vaccine.
But somebody's 38.
Yeah, I do. I mean, the NACI guidelines are under age 46, right? So we would, up to age 46, we would recommend that they consider HPV vaccine. And we do synoptic reporting for colposcopy, so we just have little tick boxes, and we now have a tick box that says recommend HPV vaccine, and we try and remember to talk to women who have been treated and recommend that. The other thing, we will write a lot of prescriptions in the colposcopy clinic. And one of the things that I think you all know is the pharmacy will just give it on the spot if you have the vaccine.
Can I just quickly interrupt? If you're going to ask a question, would you mind turning on your microphone, because we have people on WebEx and they can't hear your question otherwise.
Okay.
Thank you very much. Sorry.
Oh, yeah, okay.
So what age is older women on the 3 vaccine dose?
Unfortunately, it's way younger than you think. It's like, what was the study? Was up to age, it was the 16 and over is older
16,
women. Yeah.
Oh, okay.
And okay, so yeah, I know it's kind of sad. I mean, I don't know if we are all ultra old women, but I don't think there's a description for that. So I'm not going to go through the boys thing, but I just put this slide up because I do want people always to keep in mind that the big burden of HPV does fall on women. I'm a gynecologist, right? Cervical cancer screening, I'm just going to say a little bit about it. Our program in BC began in the 1950s. It was the world's first ever population-based screening program. It's been widely published on and emulated. It's our provincial program. It's all done, the cytology is all centrally. It's organized colposcopy. And in spite of that, our coverage, women who have had a pap smear in the last 5 years, 75%. So if you think screening is the answer and people say, well, you don't need the vaccination because you have a good screening program, in spite of every effort that we've made through BCCA in my 25 years that have been there, we're unable to get almost a quarter of women to regularly participate in the screening program. That quarter of the women accounts for about 70% of the cancers that we see. So we're not doing as well as we would like, and we're bang on the Canadian average. Okay, why does screening not work very well? Well, lots of women aren't being screened. I've just pointed that out. There's also, some performance issues. And one of the things about being a family doctor, I've been in the shoes of the family doctors, and I know there's a couple in the room. And I remember when I started in Yellowknife, I remembered a woman who was like a gravida 10, right? And I stuck the speculum in, and the vagina was just billowing into the thing. And there's a limited amount of time you can spend looking for that cervix to do the pap smear, right? Like, I mean, there's a point where it's not really reasonable 10 minutes, 15, 20. I don't know what the point is for you. Probably for me it was about 5 minutes. So what do you do then? Well, you take the stick and you swirl it around somewhere up top and hope you get somewhere near the cervix. So, there's those kind of difficulties. Sometimes the cervix is not always accessible with fibroids, it's posterior, etc. And then also, the pap smear, we kind of think of it like a blood test where you're measuring a hemoglobin. It's not. There's a human being looking at a slide, and it is possible for things to be missed. And, sometimes there's scant cells, sometimes there's a whole bunch of inflammation or blood on the slide, and they're going to have to find those 2 pre-malignant cells that are on there. And there's been lawsuits about that where people scrupulously look at a pap smear after someone's diagnosed. Oh yeah, we found 4 pre-malignant cells on there that the cytotech missed. So it's not perfect. The reason it works well is because people are screened regularly. Having a single pap smear is not that effective. Inadequate follow-up. Sometimes we actually diagnose a pre-malignant lesion on the cytology and there's a recommendation for colposcopy and they never get there for whatever reason. They choose not to come, which is kind of interesting because why did they choose to have the pap smear and then choose not to follow through with it? I don't know. And then treatment failures. And, there's also a little bar for rapid evolution of cancer, but that seems to be a very rare event. One thing we do know, though, and I suspect all of you in the room were taught that you start with CIN1, then you get CIN2, then you get CIN3, and then you get cancer. That's all rubbish, okay? Because what happens is you get infected with a low-risk virus or you get infected with a high-risk virus. And if you get infected with a low-risk one, you get CIN1 or ascus-type pap smears. If you get infected with a high-risk virus, you get the HSIL or CIN2, CIN3, and or invasive cancer. So it's not progressive like we were all taught in medical school. So pap smears have been quite effective, but one of the things we do know is that more recently it's really plateaued. I think we've accomplished what we can with pap smears. We can't get, we can't make a law that people have to have a pap smear, etc. So we've accomplished what we can. So since the BC program started, there's been a 70% decrease in the incidence and mortality of cervical cancer, but we're probably never going to get below that. Now, treating CIN is also not without problems, okay? So we think, well, it's no big deal. You go there, they do a leap, they take the epithelium off the cervix. But there's fairly good evidence that we can increase the work of pediatricians by increasing preterm delivery. Usually it's not severe preterm delivery. It's usually sort of the 36 to 40. So it's, what do you call it if it's 32? Bad prematurity. I don't know. I don't do obstetrics anymore. But it's usually not the extreme prematurity. But along with that, there's a low birth weight. Incompetent cervix is usually the cause. Premature rupture of the membranes is higher. And then on the other side, there's cervical stenosis and a higher risk of cesarean section in people that have been treated. So it not only causes incompetence, but it causes supercompetence of the cervix. And then a little bit more controversial is infertility and women who have had multiple treatments to their cervix. If you remove all of the glandular epithelium from the cervix, they have no cervical mucus and would require assisted reproduction. So I'm going to quit here, and my summary is I'm going to say the HPV vaccine, in my opinion, is very effective, best before sexual debut. I'm not going to talk about boys. It may, and there's good evidence that it decreases the risk of persistence in women undergoing treatment. And I think, from an oncological standpoint, it has the potential to eradicate almost a quarter of all cancers worldwide. And that's huge. So thank you. I think they all have asked their questions.
We've got lots of time, so we have lots of time for questions.
0116.
Well, I have a question. So if a woman, say you have one of these high-risk women, she's had the 4-valent vaccine, are you revaccinating with a 9-valent or topping up, or what are you doing with that?
So in the clinical trial, they were all, because I think that's an important question, and I think it's important for two standpoints. One is, should we do it? And the second is, are they going to have problems because they're already immune? And so we were involved in the quadrivalent versus nonavalent trial. And I would say about 2/3 in our center, our site, 2/3 of the women who were on the quadrivalent arm elected when the study was unblinded to come back and have the non-valent vaccine. I'll tell you, they had no problems. It was slightly sore when they looked at it, but they didn't get big ulcerated problems or anything. So the first part of your question is, can you do it? Yes, you can do it quite easily, okay? And we haven't had anybody have any problems. And then the next one is, should you do it? And I'm a little bit more fuzzy on that. I think if you wanted the absolute best protection possible, if you were a woman and you wanted the absolute best protection possible, sure you should. But I think I also showed you that the bulk of the lesions that we see are still 16 and 18. A lot of the young women that we see in colposcopy don't have a lot of money, don't have extended coverage, so it's not really an option. And then the other thing that I didn't go into is the 16 and 18 from an oncological standpoint are definitely the most virulent. Like they're the ones that can escape through screening, and that the progression to invasive cancer is much quicker. So the next 5, possibly there would be a better chance to pick up on screening in that. So I haven't been pushing women who have been vaccinated with quadrivalent to come back and have the non-valent. That being said, if somebody said, I want the absolute best coverage possible, I've had the quadrivalent, I hear there's a new one, can I get this, should I get it? Absolutely, they can get it. How's that for waffling?
That's great.
Question, since you said that it was 16 and older was where they needed the 3, if you had, let's say, a student who had their first shot when they were 12 and they missed the others, and then they're all of a sudden in, let's say, last year high school, so they're 17 years old, would you have to restart the whole series or not?
So I'm not the vaccinologist, but if they wanted the quadrivalent, you have to, or the non-valent, they have to restart the whole series. And you can't have 2 quadrivalents and 1 non-valent. It doesn't work that way. Well, you'd be probably fine for the quadrivalent part, but not for the 9.
No, it's Vincent.
Joined by WebEx, so maybe we can ask them if they have any question. Right, people joined by WebEx, do you have any question? You can ask right now. Silent mean no? Okay, thank you. And we have one question here.
So to continue her question, this girl who has had 1 shot, and then she says that.
Sorry, would it be easier if you paid for this on paid?
Do you know, can I actually defer? You've got the vaccine people, the vaccinology people coming. My feeling is, I think there's probably a time limit that you have to do it, but I think the other thing is that because she had her first one at 12, she might be a different animal than what I see in the office, right? Because I see people that are getting vaccinated at 26, so it's really easy to answer that question. They need to start over if they're 5 years later, right? But I think, I don't know the answer for the pediatric
And I
population.
doubt it's been subjected to a clinical trial.
Yeah.
Do you know, Marilyn? If you have that big gap between the...
But isn't Quebec doing the first one in grade 6 and the second in grade 12 or something? It's not... Oh, they're doing 1, 6 and then skipping the last one when they get,
Well,
okay.
we've got Dr. Olga be coming.
Well,
so-
exactly. I mean, ask this one to the vaccinologist, because...
Yeah.
A year, but it's pending past 5 years. So we don't know, like if someone dropped the vaccination, went past a year, and then what do we do with that last 1 or 2? Essentially, the answer comes down to almost restarting at
Like only during that 18.
So that would be the saddest answer, but the truest at this stage. But TBA, I think there's actually a trial coming out at the extension of what happens in the second and third in the older population, but the data's not out yet. We don't have enough of it that's robust.
And then he might be going to
You know, and the other thing is if you actually look at some, you know, sort of drill down at some of the data in the randomized trials, there are women that got a single dose of vaccine. They do get some protection.
They do.
But I think it's unlikely they get all the protection.
They don't get complete protection. We don't know how long it lasts. So the
November
best is to tell
5th,
someone to quickly and
1985.
efficiently get it done. Now, there are people who do it for coverage, as we know, where they split the vaccine.
Sorry, November 5th,
The best thing you
1985?
can tell someone is the year that you have enough coverage, do 2 in the later part of the year and do 1 at the beginning part of the next year. So divide it that way, because schools cover it that way, like SFU and other places where they give you a lump sum of money each year. So dividing it that way. Otherwise, people drop off the scale completely.
Okay.
Same
And I
with
mean, what
extended
with
benefits.
this
Mine are
family
like
comment,
that.
what
For
do you-
example, you get a certain amount of money per year for services. So doing it 6 months of the year and 6 months of the year is the easiest. So encouraging that, because dropping off does cause problems later on.
Okay,
You
that's
just
fair.
can't tell them what to do. So.
We have a question.
Okay. Thank you. That was really interesting. Okay, so our next speaker is Dr. Tinus Wasserfall. And Tinus obtained his medical degree from the University of Stellenbosch in South Africa and completed a residency in family medicine in Windhoek, Namibia, and in Stellenbosch, South Africa.
And so, for example, if he's in Cambodia
Dr.
and
Wasserfall has been
we're
practicing
not
as a family
in
medicine
emergency,
physician in Canada since
and he has to
2001,
be,
with a
taken
practice
somewhere
focusing
else,
on
or
HIV
if he would
care.
rather have medical care in a different country,
Dr.
is that
Wasserfall
covered?
is a consulting physician at St. Paul's Anal Dysplasia Clinic and a member of the International Anal Dysplasia Society. So please welcome.
Everyone, and thanks for the invitation. And yes, there is an International Anal Dysplasia Society. It was just established, I think, about 2 years ago. So yeah, that's exciting. So we are moving ahead in the world of anal dysplasia. Just wondering, can everybody see me from here? Is it okay if I sit, or would you prefer me to stand? Yeah, I think I'm good with that. So my disclosures are there. I always start my talks with saying that I have another disclosure, and that I am very sympathetic to the anal canal. This is a piece of human anatomy because it's my field that I work in, HPV infection. That's often, underlooked and sort of make patients and often physicians squirmish. But it's important because anal cancer is quite a devastating disease, and hopefully mitigating my bias, I will raise your awareness of this issue today. I know that it's something that also needs to be on our radar. So learning objectives, we're going to look at the burden of HPV disease in male, look at HPV screening in males or other people, explain the efficacy of the quadrivalent vaccine in males, and talk a little bit, if there's time, about our unfortunate gender-specific immunization program. So as you all know, the HPV is a double-stranded DNA virus.
So it's raw.
There's hundreds of types. There's a few anogenital types, and you've heard these numbers from the previous speakers. 16 and 18 account for the majority of cervical and anal cancers, and the non-oncogenic warty ones are the 6 and 11. And that's just a diagram showing this family of HPV disease, from hand and foot warts to genital warts to cancer. So the HPV virus, in theory,
August 2018.
infiltrate, because it wants to be in the basal cell layers for replication through microabrasions, whether this is the anus or the cervix or other parts of the body, and the cell cycle then life cycle of the virus then starts. So how HPV actually cause abnormal cell growth is that the body has a wonderful way of, if there's DNA damage to whatever cells, there's a mechanism of DNA repair and to inhibit abnormal growth of cells. But because of the HPV virus, which is itself a mutagen, and also because of the proteins that's associated with it, it inhibits this process, one of them P53, and so there's no cell repair and you get abnormal growth of cells, being it a wart or dysplasia or cancer. So this is a slide to show the spectrum of HPV disease, and biologically, anal cancer and cervical cancer is the same disease. There are differences, but basically biologically the same thing. We start on the left with normal, cells keratinized and became anucleated in the squamous cell area. Then you get warts, going up to CIN or AIN2 and 3. We talk in the field of anal dysplasia, we just talk about high grade and low grade. Until you have the whole cell layer growing aberrant cells, and you end with microinvasion, and that's the definition of cancer. We in anal dysplasia do not like the term carcinoma in situ. It just has a lot of negative connotation to it. Unfortunately, some patients who come from the periphery will still come in with diagnosis of carcinoma in situ of the anal canal. which some people actually, unfortunately, in this province have gotten chemoradiation therapy for. And in the world of anal dysplasia, we really don't like that term. It's high-grade dysplasia until it infiltrates. Looking at the clinical spectrum of HPV-related disease in male, we know genital warts, perianal warts, penile cancer, and then also some oropharyngeal cancers. And this is looking at the age-specific incidence of, HPV infection in men by age group, and we see there's a sort of a bump here, is presumably after sexual debut and probably related to sexual partners. But there's quite a high incidence, even later in life, of HPV infection in men. If we compare that, and that was all comers, if we compare it to MSM, men who have sex with men, the rates are actually much higher. And there's different reasons to explain that, whether it's more sexual partners, anal intercourse, these are MSM negative men, changing sexual practice. But so we see a higher burden of definitely anal HPV infection in men who have sex with men. But interestingly enough, in men who have sex with women in these 3 studies, not as high as from the previous slide, you can see the numbers are 50 to 60%. In men who have sex with women, their anal HPV is not non-significant. It might be up to 10%. And patients often ask me this in my clinic. I mostly see MSM patients in the anal dysplasia clinic, but 20% are just regular women who got their colonoscopies and was found to have anal dysplasia, or men. But I've never had anal intercourse in my whole life. And what I always tell patients is there's not a fence on the perineum for HPV. It's a field effect. So people get, through autoinoculation, do get anal HPV infection. Another interesting point that's been shown on this topic is that women actually have far higher rates of anal HPV infection than cervical HPV infection. Although it seems like when a woman has cervical HPV infection, there's a higher likelihood of developing cervical cancer versus the rates are 1.8 in 100,000 for women to get anal cancer. So it's an interesting phenomena. I always find that interesting, and I don't know what the explanation is for that. It must be anatomical. So this is some transmission data that I find very active. A lot of these studies about HPV transmission has been done in university students, because presumably coming into university, they've not been sexually active. University is a great time, fun time for doing a lot of things. And then looking at their HPV acquisition and developing signs of HPV disease. So in the first one, they looked at sexually active male university students, 18 to 20, followed them over a time period, and looked at detection of HPV DNA, and this is anogenital HPV DNA under their fingernails. And 31% of them had genital type HPV on their fingernails. 25% had high-risk types, oncogenic types. So that gives you an idea of how it's transmitted. Another study confirmed DNA sequencing of HPV-16 carried at both the genital and fingertips of sites of men, and this comes to this autoinoculation that I just spoke about. Another study showed HPV transmission through finger-vulvar contact in women, so it's autoinoculation in a lot of cases. And patients often ask this question, well, I have HPV disease, I don't want to infect future partners, would condom use help? And there's different studies, but condom use gives some protection, but you don't put condoms over your fingertips, right? When you have sex. So it's of some benefit, but definitely not 100%. Quoted by some studies as 60% protection. If we just look at the history of HPV on the slide, this is from the UK. From the 70s to late 2000s, the number of diagnoses of genital warts, you've seen it has improved dramatically. And I mean, whether this is changing sexual patterns, there's a lot of social reasons for this, but it's on the rise. So with that, you could say that would be a marker, what I think, of HPV infection being on the rise. Another interesting study that I found was, it's once again a university cohort, males and females. They followed them when they acquired their HPV 6 or 11, and then followed them to see what is the time until they develop genital warts. And it was very interesting to show that in females, they would develop genital warts much sooner the males, there would be a much longer lag for developing genital warts. And what you can detect from that is, do you think that is the males, infecting more females because they have no idea, maybe use less condoms because they don't have HPV on their radar, because they know they haven't been infected. And, my practice is anal dysplasia and then mainly MSM, and we deal a lot with genital warts. I know it's not something life-threatening, but it comes with a lot of psychological things associated with it. And this study just showed people get depressed, fear of rejection, they feel guilty. So it's not just a wart, it comes with a psychological part to it. Now, I don't know any of you who treat warts. There's different treatment modalities. In my clinic, I mostly use cryotherapy, but we have a lot of other options. But even at their best, they're not 100% at clearing. And if you look at the second column in the slide, they all have high recurrence rates. So my experience is like patients with genital warts often repeatedly need to come back to the clinic for repeated treatments, even years later. And these treatments are not without side effects. They can cause scarring, painful, and the psychological part. This is not a topic that's specific to male HPV disease, but it's something that I found quite interesting and in the same way also disturbing. I don't know if you've heard of recurrent respiratory papillomatosis. It's got a bimodal effect. It's either children 2 to 4 years or at the adult onset of 20 to 40, where people develop these papillomatosis in their larynx or throat. It's mainly caused by HPV 6 and 11, which is the anogenital strain. And, it's, as I say, especially in children, it might require repeated procedures to get rid of the conyloma. But this implies, and there's other studies that look at it, that actually, most likely parents transmit their strains of 6 and 11 to their young children. And it sort of makes the whole debate about should be vaccinated to me just so much stronger. Would you as a parent ever want to, or your daughter want to, transmit anogenital HPV strains to a child that's 1 year old? And it's through saliva and I think prenatal in some cases. So we've seen this slide also before. What percentage of these cancers, cervix, anus, vagina, penis, are strongly associated with HPV infection? So cervix we've heard about. The anus, they say 84%, but I think there's more recent data that shows 90%. So anal cancer is mainly caused by HPV infection. You've seen this slide as well. To the left, what is the impact on men? Penile cancer, which is luckily rare, oropharyngeal cancer, which you're going to hear about later in this talk, and might be an upcoming thing, anal cancer, and then genital warts, which we've spoken about. If you look at what age group gets anal cancer, it's mainly, and this is what I've seen in my practice, it's mainly in the later 40s, 50s, 60s. These are the patients who develop anal cancer. It's not at a young age, or even if you have anal HPV infection, and that's when we get to screening later, we'll talk about why we also feel for anal cancer screening. Early screening is not really indicated because we don't see anal cancer in young people. But we do know that with sexual debut, people acquire their HPV infection, and it takes, in most people, decades for it to develop into anal cancer. This is US data looking at the rates of anal cancer between men and women over the decades. And in the general population, women are much more likely to get anal cancer, but it's still low compared to other cancers. It's 1.8 in 100,000, and men is, I think, I can see it about 1.5 in 100,000. But what's more disturbing about this is, once again, as I showed you with the wart slide, is from the 70s to now, anal cancer incidence rates have definitely increased. And the question is it going to increase more? And then there's questions, why is this? Is changing in socially, how many sexual partners people have, sexual practices, but it's definitely on the rise. So who would be at risk for anal cancer? Definitely people who have high-risk HPV strains, because like 6 and 11 and a few others. HIV infection is a very important risk factor, and I'll talk to you a little bit about this in future slides. Definitely multiple sex partners, smoking, because we know smoking, people who smoke do worse with HPV infection, and then people who has a weakened immune system. That is, people who are on biologics for colitis, people who have transplant, they've all been studied, they have higher risks of getting anal cancer. If we just look at men who have sex with men and their anal HPV infection rates, as I said, in the HIV negative population, the first bar is about 60%, but as their immune systems weaken, going from CD4 counts from 500 to 200 to less than 200, it's almost 100% anal HPV infection. So HPV and HIV are not, there's some symbiotic effect that people with HIV and people with badly controlled HIV has worse infection and more cancer. Interestingly enough, despite the current wonderful area where we are, where everybody, well, in the Western world go on antiretroviral therapy for HIV disease, anal cancer rates has not decreased like many other cancers has. So we, in the HIV world, expect to see a rise in anal cancers over the next few years. So I just want to, once again, just put into perspective what is the incidence rate of anal cancer. As I said to you, in women it's 1.8 per 100,000, men 1.4. Cervical cancer, prior to cervical pap screening, was 40 to 50 over 100,000. Currently it is 8 per 100,000. But if you look at anal cancer rates among HIV negative men who have sex with men, is 35 per 100,000, which is quite high and much higher than the general population. If you look at the HIV positive MSM, I put a number there of 75 per 100,000, but there's other studies that have quoted up to 135 per 100,000. So it's really a group that's at risk for getting anal cancer. And to put it a little bit more perspective, colorectal cancer in Canada is 56 per 100,000, and breast cancer is 109 per 100,000, just to give you an idea. So now we're going to talk about who should be screened. Well, I don't think the general population should, the numbers are too low to have a screening program like a cervical screening program. But I don't know who of you are your family physicians. There's a very simple test that can detect anal cancer very early, and it's very cost effective, and that's how I've diagnosed 99% of the anal cancers that I've diagnosed in my life, is just doing a digital rectal examination. So if a patient comes to you for a cervical pap test, do a DRE, because most cancers are palpable. It's a firm, palpable nodule, and most cancers that I've diagnosed just before I've done these other tests. Another thing that I always tell to family physicians, or maybe, I don't know, gynecologists deal with it, if a patient says, I have a hemorrhoid, because we see this, unfortunately, I've had a hemorrhoid that bothers me now for 2 years. And they never get examined, they get prescribed Anisole or whatever, and then they finally get to us and, it's advanced anal cancer. It's a very sad story. So I would really press hard for you clinicians, when you have a patient with anal symptoms, to do a thorough perianal exam and a thorough digital anorectal examination. I think it's a basic test, and you can do a lot with this. But now going to screening more specific populations. So yeah, we do, in anal cancer screening, we do a anal pap test. So it's a Dacron swab. I don't know if who of you know this. It's a Dacron swab. It's like a rough edge swab. And we use a thin prep solution, which is a liquid cytology based. I know other provinces, I think, use it for cervical screening too. And it's basically that swab gets put into the anal canal, past the anorectal junction, and clockwise get returned, and then it's put in the liquid cytology. And the terminology that we get back from the labs are much like the cervical Bethesda system. We get LSIL, HSIL, ASCUS, and ASCH. Unfortunately, the anal pap test is not as good as the cervical pap test. It's often false negative. It's very specific. So if we get an anal pap test back that says HSIL, it is HSIL. But anal pap test that comes back with LSIL, and if I do further examinations, often HSIL if you do biopsies. But at least it's the only screening test that we have at the moment. Better would be to be able to screen for HPV oncogenic strains with that. That would be a much better way, and in the States they do it, but it's not funded by our system. So who should be screened for anal cancer? Well, as I said before, like everybody over 40, when they go for complete physical, should have an anal examination. But I'm talking about the anal pap test. All HIV positive MSM should be screened. All HIV positive MSM over 40 should be screened. We have a question mark whether all HIV positive men and women, regardless of their sexual orientation, should be screened, because there's been a lot of studies to show, for example, HIV positive IVDUs who are heterosexual also have high incidence rates of anal HPV infection and anal dysplasia. Should transplant-associated immunosuppression patients be screened? We don't know yet, but it's something that's on the radar. We don't have the answers for that. And another important one, and I think there's been studies about this, in women who's had multifocal HSIL, like they've had cervical dysplasia, they've had especially vulvar dysplasia. There's been studies that show those women are very, very likely to have anal dysplasia as well if it's multifocal, and maybe they should be screened or refer for high-resolution anoscopy. So in this slide, I just want to show you what these dysplasia grades look like. So this is what I do through a microscope. This is the anorectal junction, and this is a high-grade lesion. I'll explain to you a little bit later what's the features of that. That's the pap test that we did, and those are the high-grade cells. You know, they have big nucleuses, they're hyperchromatic, and the cytoplasm are small. And if you look at the actual biopsy, the whole thickness of layer of the epithelium is aberrant cells. This is anal squamous cancer. So what you see on pathology here is you've had invasion into the stroma of the cells. This is what it looks like on high resolution with a microscope, and this is what the pap test look like of cancer. So this is what I do. This is a colposcope. We actually use a microscope, but I just had a picture, but it's similar. We put an anoscope into the anal canal. We apply acetic acid, basically vinegar. We look at the area that focus on most is the anorectal junction, similar to this cervix. It's a little bit more difficult in the anus because the anal canal sort of collapses on itself, so it's quite a maneuvering to do it. We have used basically ENT equipment to do biopsies, and then if we find lesions, we treat with, this is a laser, it's RC ablation, but we also do electrocautery of lesions. So this is what it looks like under high magnification. This is the rectal columnar epithelium, and this is the transformation zone of the anus, and there this pink kind of fleshy, this is the anal canal, this squamous epithelium, and this is normal. If you look at this, of course, we've applied vinegar on this, acetic acid. This is what we call acid whitening, where that's probably going to be a high-grade lesion, and you see atypical blood vessel patterns there. I don't know if you can see it on the screen, when you get these little areas of punctation. And those are the lesions that we're going to biopsy and treat. This is what warts looks like through endoscopy. Warts are very friable. They're raised, they have papillary surfaces, they have different kind of blood vessels, and very hard to treat if it's this extensive. Just want to show you another example. So this is the anorectal junction. We apply acetic acid with a swab, and there you can see a high-grade lesion. They're usually flat and well demarcated. That's the same lesion, and that's the lesion that we'll biopsy and then ablate at a later stage. These are the atypical blood vessel patterns that we see with high-grade dysplasia. This is what we call punctations, like little dots, and we know we'll go and biopsy there. This is the other blood vessel presentation that we see. It's called mosaicism, and we will definitely biopsy there and then treat these lesions. This is unfortunately what cancer looks like. You get aberrant grow, and you can't see it on the slide clearly, but the blood vessel patterns become what we call atypical. So anal cancer, if detected early, is very, I mean, they get chemo and radiation and plus minus excision, but the survival rates are fairly good. But the key home message is it needs to be detected early, and that's our job, because I've been through quite a few patients in my life who has died of anal cancer, and it's a terrible death. And so really for anybody involved in that field, it's really important to think of it, to screen for it if appropriate, and to do a thorough exam. In the last few minutes, I'm just going to talk about the HPV vaccine and the study that it did in men. I'm not going to talk about the bivalent vaccine because it wasn't studied in men. So I'm going to talk about the quadrivalent one, which was specifically studied in men. The nanovalent one, there wasn't a male study, so that's why I'm going to focus on the quadrivalent. So the quadrivalent has 6 and 11, 16 and 18. It's a viral capsid that elicits an antibody response to those strains. So I'm just going to look at the male part of the study. So the males were randomized to placebo versus the quadrivalent, the Gardasil. They got 3 doses, and they were followed for 36 months. There were about 3,000 men, 16 to 23, and then they had a subset of men who have sex with men, about 600, same age. And the inclusion criteria, exclusion criteria was no genital lesions, no history of warts, and a lifetime sexual partners of less than 5. And I know one of the PIs who worked on the MSM study, and he says it was very hard to recruit for the MSM part of the study. So the objectives was to look at the occurrence in the study group of external genital lesions, warts, and neoplasia, and anal neoplasia in the MSM sub-study, and they also looked at antibody titers and persistent infection with those strains. It's a busy slide, but what it showed, this is placebo and this is the vaccinated group. If you look at just external genital lesions, there was a huge rate of efficacy at up to 36 weeks of, 36 months of preventing this. If you look at, in the MSM sub-study, looking at anal dysplasia, once again, that's the vaccine group, that's the placebo group, and there's really, really a good efficacy rate of preventing future anal dysplasia. I mean, you must remember these patients had to have less than 5 sexual lifetime partners at entry of the study. The study would have been better if it was a study done on 10-year-old boys and follow them 15 years out and then see, because I think the numbers might have even been different, because you can assume if you had 5 sexual partners, you've probably had quite a bit of exposure to HPV already. But even with that, the efficacy rate was really good at preventing anal dysplasia. And then also the same for looking at persistent HPV infection. This is the placebo group, this is a vaccine group, and it was very effective. So we know that quadrivalent has been approved for use in men, 1926. Why only 26? Because the study only went up to 26. And it's approved for preventing 6, 11, 16, and 18 infection in males. They actually got the indication preventing anal cancer caused by 16 and 18, also for warts and infection. And so we know there's been a lot of recommendations from different organizations suggesting that all boys should be vaccinated started at age 9. But that hasn't happened in Canada. And there's only very few provinces who actually vaccinate their males. We know that, as a previous speaker said, the vaccination uptake in females are, in my opinion, abysmal. Once again, the Australian data are just showing what happened just to warts if they have a male or female vaccination program, and you see this dramatic drop-off of warts. And they also compare it with men who have sex with women versus men who have sex with men, and there's been a quite significant decrease. Same for New Zealand, pre-vaccination and post-vaccination, the percentage of people with developing genital warts. You know, we look at all these different vaccines, diphtheria, measles, mumps, pertussis, name it, and we look at rates of these disease pre and post vaccination. And we know most of these vaccines that has been proven to be efficacious has made a huge difference on public health. The WHO came out with this list of top 10 great public health achievements in the past century. And vaccination was number 1 on the list. And you can look at the other ones. So my questions about this female-only initiative is, are we as physicians providing the best care by only vaccinating our females? Are we missing an opportunity to protect the population at risk for HPV disease? And we can talk about that a little bit more. Is it ethical that men should not be able to directly benefit from HPV vaccination? Is it ethical to leave the burden of HPV prevention only to women? And recently, our ministry here in BC, as we've heard, has now approved HPV vaccine for men 19 to 26. And these are men who have sex with men or are thinking about their orientation, street involved, HIV positive. And I think it's a small step in the right direction, but very small. Because once again, from just my own personal experience, having a practice who's predominantly men who have sex with men, from the time of sexual debut for a typical man who has sex with men to really coming out of the closet is often many years. So, you know, it's very far from perfect. And then they made this statement. In contrast, they said if they thought it would be cost effective if you have a 50% immunization of girls, that would be cost effective. So when I read that statement, I'm like, well, if you would say that about hepatitis B vaccine, because that's a sexually transmitted disease as well, potentially, if you would say, okay, it's cost effective only to immunize a quarter of the population, I don't know who would accept that argument. And for me, it's very hard to accept this argument. So what is our role? I think our role is to talk to our patients and their parents about the importance of this vaccine for boys too. And that we, in whatever capacity we provide care, we can really influence the patient that sits in front of you's future health pertaining to HPV disease. So I do recommend that we discuss HPV vaccine with parents, both boys and girls, not just the girls because it's covered. Because a lot of people do have coverage, and I think it's really important to do that. And then there's also a CMPA part of it. You know, we have to do due diligence to offer this to parents. And I think that's my talk. Thank you.
Wow. Are there any questions? Could you press your button?
Press my button. So in terms of what we should be doing in general practice for screening, you're saying more rectal exams, obviously, but in like men who have sex with men, should we be doing these?
So we feel, once again, men who have sex with men only develop cancer late 30s, early 40s and onwards. So we would, for all men who have sex with men, suggest that they get an anal pap test, I would say after, there's no strict rules, but after 35, that's a definite consideration.
How often?
We don't know. We are so jealous, we in the field of anal dysplasia are so jealous of cervical dysplasia because everything has been studied, we know exactly the biology of it, and anal dysplasia is a very new field of medicine, so we don't know. So loosely I say every time the patient comes for a complete physical, it's probably every other year. Yeah.
They don't come for complete physicals. There's no such thing in the healthy population.
Yeah. I don't work for fee-for-service, so mostly my patients do come for complete physicals. But, well, at least at point when you see them, you have to explain to them that the screening test that's available and that, that should consider it.
And technically, we just take a cotton swab and do a pap?
No, it needs to be, it's called a Dacron swab. So it's not a cotton swab. It's, if you feel the tip of it, it's sort of very...
Chlamydia swab.
Something like that. It's supposed to scrape off cells in the anal canal.
Do we need to send them to you then? Because we probably don't have these.
That's the biggest problem with screening, and that's where we have a big issue in this province, because our clinic can screen. We can only treat because our current wait list is 2 years, just to be seen if you...
2 years.
Yes, it's horrific. So we can unfortunately not screen, but sometimes if you have a patient that you really think should be screened, find out from your local health authority. There's some of these community clinics that will do screening. What I've done 3 years back is I would take a cyto brush. The cyto brush. It's not the best way of screening, but do the cyto brush, insert it into the anal canal, do a scraping, put it on a slide and fixate it, and say it's an anal pap test. The yield is not so good, but it's at least some form of screening.
Is it covered by MSP?
Yes.
Okay.
Yeah.
Dr. Miller wanted to ask, make a comment.
Sorry, I just have two questions. One is, you mentioned the transplant community, and what we found in cervix, us privileged people, is that it tends to be people that are on prednisone specifically, not the other immunosuppressants that get the chronic recurrent CIN, VIN, etc. So I just wondered if that's the same thing you seek. So because that also applies to a lot of people who are not transplant patients with connective tissue diseases, etc. And then the second question is with regard to smoking, because we cannot clear HPV in VIN patients specifically unless they quit smoking.
Well, I totally agree with you. Smoking that's one of the first things I tell people, because unfortunately, anal dysplasia versus cervical dysplasia is very recurrent, highly recurrent. These patients, that's why wait list is so long. These patients, once you get into that clinic, you're probably going to stay in that clinic almost lifelong because you get recurrent. So yeah, and that's one of the things I tell patients when they get frustrated with recurrence, is I think you need to stop smoking. It's vital. As far as the different agents, no, I think our numbers are too small to really, differentiate which one causes more dysplasia than. Yeah, our numbers are not that big. We have a small cohort of people on immunosuppressants, so I can't say.
Hi there. So my question was, I have two questions. I have a 63-year-old heterosexual lady that was seen at the anal dysplasia clinic and has had AIN grade 2 dysplasia, is followed and has had multiple treatments. The consult letter that we had got back mentioned that there's been retrospective studies that show a decreasing recurrence in these individuals who've had HPV-related anogenital disease. So she was, in the consult, it mentioned to give her the Gardasil vaccination, so we have. Is this, I'm just wondering if this is common practice that you're offering, similar to the Cook Hospital Clinic offering it to women?
In our clinic, there's no retrospective studies on it, prospective studies on it, but retrospectively there's been chart reviews done in New York where they looked at people with recurrent anal dysplasia and just compared the two groups, who got the Gardasil vaccine and who didn't. And the people who got the vaccine, there was clearly a decreased recurrence rate. What I tell patients, so I offer a HPV vaccine to every patient with anal dysplasia. I tell them it's not 100%, cure rate, or that you're never going to have, anal dysplasia again, but that's the one thing you can do, because basically what I tell patients is I can treat a lesion, but I cannot treat the virus. And the virus is obviously there. If you're 40 or 60 and you have anal dysplasia, you are stuck with HPV virus that your body obviously is not going to clear. So the only thing that you have is try the vaccine, whether it will work or not. I mean, that's your best shot at getting rid of it.
For sure. And then just another question I had was, I have like a heterosexual female, supposedly in a monogamous relationship. Her partner is monogamous. She's 55. She's had cervical dysplasia in the past, and recently had complaints of anal pruritus and had an anal tag, and worries about her risk of anal cancer. So it's kind of, again, I call Merck and it's off-label to do the vaccine for a 55-year-old, and I just wonder the degree of benefit if cost isn't an issue for this person. And that's kind of that gray area.
Yeah, we don't know what degree of benefit is. That's the issue. But once again, coming back just to clinical practice, what I tell patients, well, the only thing that you have to lose by getting the HPV vaccine is that it's going to cost you money.
Yeah.
There's no other downside to it. And I mean, there's unfortunately not enough studies to really make a strong recommendation. So if you recommend it to your patient, you have to tell them the caveats of this is not really studied. There's a few retrospective chart reviews in this setting. But I really think this is the only thing that we have at this moment to our disposal and other than quit smoking. That.
I think we had one last question in the back.
Yes, my question is about the genital warts. I have treated many patients, male and females, with cryotherapy, but interestingly, none of the partners of each one of them has the same thing. So I wonder how transmissible is genital warts. Like I've seen patients with tons of genital warts in that area, and sometimes I refer them to a surgeon to remove them, but then the partner has none.
There's been so many studies. Actually, that's fascinating how HPV gets transmitted between couples, fingernail studies, oropharyngeal studies. So the DNA it's very transmissible through intimate contact. But if you think of it, most people who have HPV don't know they have HPV. That's the thing. So the partner might have that strain, the same strain, if it's 11 or 6 or whatever, that what the partner has who has warts, but this partner's immune system is just suppressing it in a different way so that there's no signs of warts. So, big question that people always ask me, especially in the special clinic, is should I disclose to future sexual partners that I have HPV? And it's a tough one, and we generally say no, because if you look at the studies if the general population who has been exposed to HPV, most people. So we don't tell people to disclose.
Great.
One more question.
A remote question?
Yeah.
Okay.
Hi, people joined by WebEx. Do you have any question? Silent me, no.
Okay.
Thanks.
All right. Well, thank you very much. It's really interesting. Yeah, thank you.
Okay, so our next speaker is Dr. Keys, and Dr. Keys is a clinical professor in radiation oncology, UBC. She obtained her MD from University of Novi Sad, probably saying that incorrectly, Yugoslavia, and then came here and did a radiation oncology residency at UBC. Dr. Keys is a provincial brachytherapy program head. She is a very renowned speaker and author and has a very large GU and head and neck practice. So, Dr. Keys.
Thank you very much for having me here. So, just gonna figure out whether I need glasses or not. That's no disclosure apart from the glasses. Maybe I should just bring them over here. I'm in that age group. Oh dear. Yeah, I remember seeing my optometrist some 5-6 years ago, and then I left, and he said, well, you can just go to London Drugs and get his reading glasses. And I was like struck, my God, that was my sign that I'm actually aging. So anyway, I'm now used to this. So I'll be talking to you about head and neck cancer, and I think my only disclosure is that I treated most of my career prostate cancer, GU oncology, and then breast cancer. And just more recently, I've actually joined the head and neck team some couple of years ago or something. But it has been actually quite an interesting change to come back to head and neck, because when I finished my residency, I started to treat head and neck cancers, and now I come back to it. And a lot has changed, and I'll just point out to some changes. So head and neck cancer really caused a lot of mortality and morbidity worldwide, and there is a lot of cases and a lot of deaths, and 90% of all the head and neck sites actually are squamous cell carcinoma, and this is 8th most common cancer in men and 14th most common cancer in women. And these are the sites where these tumors actually do arise. And these are really traditional risk factors. So alcohol and smoking and oral hygiene and diet, family history, genetic syndromes. But it was interesting when I started my practice, I did head and neck for a couple of years. And these were all guys, like they come in and they're in their 50s, 60s, 70s. They really have a heavy odor of alcohol and tobacco, and they just kind of stare at you, and you talk to them about treatments. And they say, are you finished, doc? I say, well, almost. I just need my smoke. And they're just out of there. They don't care about what you said. And then there is HPV, which really kind of changed the face of head and neck cancers. So we'll talk about HPV a little bit and why are we concerned about this in oropharyngeal cancer, and a little bit of vaccination, which is not very complicated here at all. And I'm glad a lot has been said already, so I really don't need to say much, and you'll see why. And also, a lot of you actually asked this question. My partner has HPV-related tumor. Am I at risk, and what should I do? So we'll talk about that as well. And also about the head and neck cancers and how they look actually different than your regular head and neck cancer. So you've seen this lovely picture of the flowers in human papillomavirus, and it's a very, very common virus, and we're not going to go into that. But what is interesting is that it actually replicates exclusively within the basal layer of the surface epithelium, so that's very important. So why are we concerned? Even in 1983, it was actually first suggested that HPV might be an agent involved in the development of some types of oral cancers. And in 2007, actually, WHO stated that HPV actually causes oropharyngeal cancer. So we also have seen this. I'm not going to labor, but there is more than 70 known types, and most of them actually really cause absolutely nothing. And then there is some strains that cause benign disease. We heard about it quite a bit, and there is some, and actually there quite a lineup here, not just 1618, but quite a lineup that cause different type of cancers. So I'll just go a little bit more detailed in how does this HPV actually cause this cancer. So what happens? So these there's some oncoproteins that these viruses actually do produce, and this viral DNA actually gets incorporated into the cell DNA, into the basal cells. And then the virus expresses these proteins, or they're called oncoproteins. They're E6 and E7. And these E6 and E7s, they actually interact with P53 and retinoblastoma gene. And so when they interact with the genes, really what happens, so let's take a look at the P53. In the normal cells, P53 is extremely important because it inhibits the cell going through the cell cycle, particularly in the face of DNA damage. And we have a lot of DNA damage that goes from smoking to sun exposure to you name it. And so this is an extremely important gene. And so when P63 actually gets binded to this E6 protein from the virus, P53 gets degraded. And so when P53 gets degraded, really that allows for unchecked cell cycling. So even though there's a DNA damage, cells are still cycling. And that actually really promotes accumulation of DNA damage to the cell cycle. So that damage is never repaired. And that, of course, leads to chromosomal instability. And that's how these high-risk HPV cells actually do get into trouble. And there is also another mechanism that really stimulates the mitotic activity at the same time of these infected cells. You have two parallel processes. And then retinoblastoma gene, again, really, there is a story that retinoblastoma protein inhibits growth by stopping the DNA synthesis and induces cell apoptosis in response to DNA damage. So again, this DNA damage. Now, this different protein, E7, interacts with this retinoblastoma gene, but then it forms some kind of a complex, and that complex, in addition to not really kind of clearing up the DNA damage that has not been cleared up, also promotes the cell cycling. So you have these two wonderful processes that actually synchronously work together. So the first process is DNA is not repaired and cells continue to cycle. And the second process is that cell cycling is actually promoted. So here you go. This is a recipe for disaster. And that's really how the recipe goes. But that takes actually a long, long time. So that doesn't happen overnight. And then in head and neck cancer, we talk about P16. So what's now P16? So P16 is a cyclin-dependent kinase inhibitor. That's another protein, very simply, another protein. And P16 is induced when this E7 protein interacts with retinoblastoma gene. And P16 is really important. It has an important role in regulating, again, the cell cycle. And mutations of this P16 increase the risk of developing a variety of cancers. So why are we talking about this? Because it's really important in head and neck cancers. This P16 can actually be stained by immunohistochemistry using mouse monoclonal antibodies. And therefore, there is a significant agreement between HPV infection or HPV-related cancer and P16 expression. So we use it in the clinic every day. It's essentially, for us, biomarker for tumor-related tumors that are actually HPV-related. There's also some discrepancies. P16 is an excellent surrogate for HPV status in our patients when we do the biopsies or resect tumors, whatnot. But P16 is not specific for any HPV subtype. So that's actually very important to understand. And so this is an H&E stain of two different head and neck tumors, P16 negative tumor and P16 positive tumor. So it's really actually very, very useful for us, and I'll tell you why. So how does HPV need to, what does HPV actually need to thrive? So it needs to have an easy access to basal epithelial cells. And when it comes to head and neck cancers, we talked about anal sites, and we talked about cervix and vulva, but really there's the crypts of lymphoid tissue in the palatine tonsil and base of tongue, and this is actually what they need. They also need some trauma to the epithelium, which I suppose it actually happens quite often in the oropharyngeal area, and also need self-differentiation and replication, which is again very common in oropharyngeal area as well. And so these are the little crypts and tonsillar crypts where the viruses actually really like to come in and then access this basal cell layer. Yes.
Is tonsillectomy any benefit to that?
Is tonsillectomy any benefit? Well, tonsillectomy is a huge benefit because you don't develop, cancer of the tonsil, but you still have the Valdeir's ring and you still have the soft palate and you still have the base of tongue. So you kind of eliminate part of it, but not all of it. So I don't know the good answer, but should we be doing tonsillectomy to prevent this cancer? I would say no, we should probably be vaccinating people, yeah. Okay, so the problem is that this persistent HPV infection, and vast majority of HPV infection we know is actually cleared in less than 2 years. So persistence of this high-risk type is associated with an increased risk of malignancy, and persistence is rare. It's very rare, so that it really needs to be underlined, but may lead to integration of the viral DNA into the basal cells. Okay, so what happens when there is a viral DNA gets integrated into the basal cells? Really nothing. Nothing happens, really. So these viral oncogenes are actually usually inhibited. And that's really where this immunity comes into a huge, it's a huge piece of puzzle. If you have good immunity, this is probably what's going to happen. Nothing. So you get exposed to virus, you get infected, but nothing happens. You actually clear up the virus. However, these inhibitory processes actually may break down, and that requires failure of several different signaling pathways. And this process happened over the period of many, many years. So the time between somebody gets actually exposed to HPV until they get full oropharyngeal cancer is 10, 15, probably 20 years or more. So, and variety of these factors, external or internal factors, can actually facilitate this breakdown, and it's essentially the deficit in immunity, but also there's some environmental carcinogens, and again the smoking comes here as a very handy carcinogen to kind of illustrate this picture. Hormones, X-rays, other viruses, and HIV, and there could be genetic factors as well. So we'll talk a little bit about epidemiology of oropharyngeal cancer. And HPV transmission is about 70 to 80% of, as we heard already, sexually active adults actually are infected during their lifetime. So majority of people actually have seen the HPV. I would say maybe all of us in this room have actually seen HPV. Let's just make it very personal. But 90% of us are going to actually clear this in 1 to 2 years. So most of us have no problems with it whatsoever as well. 10 to 30% of active infection is seen actually in young adults. And HPV is infects by direct mucosal contact. And we know that virus actually like this keratocyte stem cells in the basal layers and through to these microabrasions. And what is interesting for oropharyngeal cancer, the 60 to 70% are actually of oropharyngeal cancer are HPV related. So that's a majority now of patients that we see. And HPV 16 is actually responsible for vast majority of oropharyngeal cancer. So just one strain, HPV 16. So the issue here is not about the HPV infection, but rather who of these infected with HPV will develop persistent infection with the risk of developing cancer. And we know that being infected with HPV 16 carries a high risk, but just less than 10% of those infected with high-risk strains will actually go on to have progressive disease and cancer at the end. And we need a test that allow us to forecast which ones of those infected will actually have the cancer at the end of the day. And we don't have that test yet. So oropharyngeal cancer incidence have actually increased, and this is the SEER data until 2004. And I think these curves are actually going to look very, very different if you look at it now 10 years or 12 years later. But essentially, this is oropharyngeal positive cancer. This is oropharyngeal HPV negative cancer, and these are overall, like incidence have changed actually very little, but HPV positive cancers have actually go quite significantly up. And if you look at BC registry data, again, this is a laryngeal cancer in red, and then oropharyngeal cancer starts to go up. This is only until 2006. I'm sure this curve is actually going up, and oral cancer is going down, which is directly related to smoking. And these are the smoking rates in BC, age 15 plus, until 2007, and so they're definitely going down. So most of these cancers are actually in the tonsillar area, soft palate, and the base of tongue, while their ring is in the oropharynx. And sometimes occasional laryngeal cancer can also be HPV positive or P16 positive. We don't call them HPV positive, we call them P16 positive, but most of them are really base of tongue. So these are now younger patients. As I told you, I don't see very many of these kind of smokers who just kind of want to get out of their room and have another puff, and they can't wait until I finish what I want to tell them. So these are younger patients. They're your kind of, executives and bankers and teachers and doctors who are just absolutely stunned. They're in their 50s, and all of a sudden they're sitting in your office and they have huge mass at the back of their throat. There's no history of smoking. They exercise. They're healthy, and they don't, drink much. So that's a completely different kind of patient that we see. And it's of course associated with sexual behavior, and the risk factors are high number of sexual partners, and history of oral genital sex and oral anal sex, and decrease in the age of first intercourse for men, and genital warts, and chronic periodontitis. I can't pronounce that. And abnormal pap smears in females or in their partners. Tonsil and oropharyngeal cancers increased in male, and there's this male predominance despite reduction in smoking. And so this decline in smoking history, as we saw, probably is related to overall decline in tobacco-related oropharyngeal cancer, but the change in sexual and social behavior is probably related to increased incidence of HPV-related oropharyngeal cancer. And it's really interesting, why is there male predominance? And some people think that the fact that women appear to be exposed more frequently to HPV, actually. And the secondary effect is really that they develop antibodies, and defense against HPV is the immune system is working maybe much better and much more effectively. And that's why they clear up the infection more effectively than men. So therefore, men actually has more oropharyngeal cancer. That's just a complete hypothesis, but we don't know whether that's true or not. So if you just look at the anatomy, so smoking would actually be responsible for also oropharyngeal cancers, but actually smoking and cigarettes and carcinogens actually act on the surface of the epithelium. And these cancers that are caused by the tobacco or alcohol, they look completely different clinically. So they look like ulcers, and they're, kind of typical cauliflower type of presentation, and they're very painful. In contrast, the HPV kind of gets into these crypts, and then the cancer starts kind of deep down into the tonsillar area or base of tongue. And cancer really presents as submucosal swelling, so you really don't see them. And very often you examine these patients, and you know that they must be HPV, related oropharyngeal cancers, and you can't see absolutely anything. Tonsil is completely normal, so is base of tongue. So where is the cancer? So they look also different under the microscope. Non-HPV associated tumors are usually well or moderately differentiated and keratinizing, while the HPV-related actually are poorly differentiated. They're non-keratinizing, and they have a distinct basiloid appearance under the microscope, completely different phenotype of the cancer. So often the patients present with the painless neck mass. That's the most common presentation. And usually they have cystic lymph nodes. So they're quite big, actually, lymph nodes. And the primary site, as I mentioned, may be very, very difficult to find. Base of tongue looks normal when you scope them, and when you look into the mouth, you don't see anything in the tonsils. And they really commonly have early T stage, which means small primary tumor, and then advanced nodal disease, which is these big cystic nodal metastatic deposits in the neck. And primary sometimes is actually never identified clinically, although it may be actually found on a PET scan. And so what we usually do is we send patients, or GPs or ENTs usually send patients for the final aspect of the neck nodes, and then we also do the PET scan. And as I said, 80% of all of these tumors are actually related to P16. P16 positive. So it's interesting to look at now these cancers, and they're same cancer, oropharyngeal cancer, and they're actually two different, completely different phenotypes. If this is the HPV-driven cancer, so usually the primaries are small, often nodes are large. They usually have more distant mets than the other counterparts. They're poorly differentiated, P16 positive, and actually they have a very good prognosis, which I'll show you as well. But if somebody has smoking-driven cancer, they're usually large primaries and painful primaries, very obvious. Nodes are involved, but a little bit later. Distant mets are not as common. They're well or moderately differentiated, P16 negative, and then they have completely variable prognosis. Now, if you add smoking into this mixture, and somebody has HPV-driven disease and they smoke as well, this probably is actually the worst possible combination because you have two different carcinogens, and they have the worst of both worlds. And just to kind of give you an idea, there is a lot of Chinese population in Vancouver, so we actually see a lot of men and women who have nasopharyngeal cancer, and this is again completely different entity when it comes to head and neck site. And these oropharyngeal cancers are actually really so incredibly similar to nasopharyngeal cancer. So two different cancers, but they have same carcinogen and same phenotype. So we already said what is listed here for oropharyngeal cancer, but the same is exactly true for nasopharyngeal cancer. So these are related not to HPV, but to EBV virus, and they behave the same. They give big nodal metastatic disease. They actually really respond well to treatment, and they have actually quite good prognosis. So this is a very common type of picture. So there is a big enlarged node here on the CT scan. This is the base of tongue and tonsillar area, so base of tongue more so than tonsillar area, but this looks actually completely normal, right? When you do a PET scan, this is actually where you find the primary. Here's the primary in the base of tongue. So PET scan has been extremely helpful. So as I said, these are younger, healthy, fit patients, and these are my present patients. And I've never seen this guy, but, you know, he's done a lot of actually to promote kind of just awareness of actually what's going on with this type of cancer. So one case history, I just saw recently this 42-year-old female, and she was previously healthy. She works at the airport for Air Canada. She's an engineer there. And she went to see her GP with enlarged neck node. And she was otherwise completely asymptomatic, and the ultrasound was done and showed 3.5 centimeter lymph node. And by the time when she went on to see her ENT doctor, she already had bilateral lymph nodes, and the fine needle aspirate was done, and this was squamous cell carcinoma P16 negative, and the normal ENT exam. So it completely makes no sense. And we did a PET, and she does have bilateral nodes and asymmetry in the base of tongue. And then we also took a careful history, and she does have cervical dysplasia in 2003 that was treated, and now she has normal pap smear. So even though this is P16 negative and FNA, this is probably false negative result, and I stage her as a clinical T1 and T2C base of tongue squamous cell carcinoma, most likely P16 positive. So why am I kind of dragging this P16 story? So this is her base of tongue, and these are the bilateral lymph nodes, and this is how usually they look on a CT scan. They're quite cystic. So does it matter? It really actually does matter for us. So it's helpful for us to identify the site of the primary tumor, right? And so if we can't see so when we treat these people with radiation, we have to know what to cover with radiation. And so we cover the disease that is visible on the imaging, but if nothing is visible on the imaging, we still have to cover the possible primary sites, which really are tonsils and base of tongue. So also, as I just mentioned, really help us in delineating our treatment volumes. Also help us really estimating the prognosis for these patients and telling them how likely are they going to do well or unwell. Help us with the follow-up to know whether we should be looking for the mets or we should not be looking for the mets, or do we expect them or we don't. And also there's a proposed new strategies actually for treatment of oropharyngeal cancer because they're quite sensitive to chemo and radiation. So we maybe we can be even less offer less intensive treatments with the same chance of success. So this lady got, she's just going through her treatment. She got 7 weeks of radiation, daily treatments, Monday to Friday, weekends are off, and then every 3 weeks she has a concurrent cisplatinum. And this is just how radiation fields look like. These are her nodes, base of tongue, with a very high dose of radiation, 70 grays, and this is the dose of radiation that's covering kind of rest of the neck nodes, and here you see up to like 50 grays, the rest of the neck and rest of the base of tongue. So when we look at the outcomes of these patients, what we do notice is that HPV cancers are very sensitive to chemoradiation. And that's really a part of the good news. And the stage for stage, the recurrence rate is actually less than a half rate of HPV negative cancer, so almost twice as many are actually cured. So this is just an interesting article. They look at one randomized trial, so they pull out all the HPV positive cancers, and these are HPV positive and HPV negative, huge difference. And then they look at, when they look at actually P16 positive versus P16 negative, these curves gets even wider, and the reason is because I guess they're just trying to find HPV 16 here, but when you look at all the other HPV possibilities, and they're actually P16 positive, then the difference actually becomes even greater. And so if you look at overall survival, this is stage 4 disease versus stage 1 or stage 2 disease. They're all pretty much the same. While if you look at somebody who has HPV negative tumor, so induced by the smoking and alcohol mostly, so there's a huge difference between different stages, stage 4 and stage 1, while here there's really very little difference. So even though they have these bulky nodes, they actually do quite well. This is how we used to do radiation when I finished my residency training program. It was a huge field, really kind of covering a lot of normal tissues. And if this was a tumor, a lot of normal tissue would have been covered with very high dose of radiation, and that's all changed now. So these are the new, just to illustrate how we can actually shape the radiation dose around the tumor and around the lymph nodes that we want to treat and spare the uninvolved normal tissue. So it is actually far less toxicity that we are causing for the patients. But in the recent years, we figure out that just like in cervical cancer, if you actually add chemotherapy together with radiation, it works much better and we cure more patients. So now we are thinking, well, maybe we are actually administering treatment that is maybe too toxic. Maybe we can actually not give them chemotherapy, or maybe we can give them some alternate systemic agents like cetuximab, or maybe we can even reduce the radiation dose. So this group of patients is, I think, now becoming a focus of intense research as to how to de-intensify the treatments to actually give them less side effects with hopefully the same cure rates. And then there is surgery. So at VGH we do have robot, and transoral robotic surgery is something that is just really coming into play, and there's a huge national trial that we are looking particularly into these HPV positive tumors, where the surgeon will go in and with robot actually dissect the tonsil and dissect the base of the tongue. And so here is Ethan Prisman. He's the only surgeon who is actually doing this at the moment, and here's a robot. And this was in Vancouver Sun, and so it's actually wonderful. I went to see one surgery. It's actually quite remarkable how minimal invasive that surgery is. And in the past, they all had manipulectomy to kind of get to the base of tongue. Now he just opens the mouth wide, puts the robots in, and just dissect what he needs to dissect. It's actually quite fascinating. And significantly less blood loss and possibility of avoiding tracheostomy and shorter hospital stay and fast recovery, and speech and swallowing is much better. So that's the robot. So the last issue is, my partner has HPV-related tumor, and am I at risk, and what should I do? So there is actually a really nice study that looked at exactly that question. So they know that many patients and their partners actually do have this enormous anxiety about this HPV transmission from the partners who actually do have the cancer, and so this study is kind of trying to address that issue. So they looked at 164 patients, and they looked at all of their partners, spouses, and there's 93 of those that were willing to come. So they did an oral rinse for both patients and partners and blood samples, and they asked them some questions about sexual behavior and whatnot. And this is what they collected from blood, and they looked at the prevalence of any oncogenic HPV, so all of these strains were looked at. And this is, I think, very interesting. So this is the general population, U.S. general population. These are the partners, and these are the patients. So any oral HPV was only found in 64% of the patients who actually had known oropharyngeal cancer. So it's not 100%, it's 64%. and 43 in partners, so very low actually. And among women, it's only 23, but look at the males, 33. So huge difference between males and females.
2.3 or 23?
Sorry, previous, let's take a look, if I can. Okay, so 4.3. So these are partners, 4.3. Any women partners, 2.3. Any men partners, 33.3. So these are the healthy partners, and these are the patients. Okay, and this is the general population. So in general population also, any HPV at baseline is 4.3 for women and 14 for men. But if they have a partner, men who have a partner that has any oropharyngeal cancer, it's actually 33, so it's double. And that is to say that most partners of patients who have HPV positive oropharyngeal carcinoma do not have any detectable oral HPV DNA, suggesting that either that oral transmission is rare, and or most partners effectively clear any active infections to which they're actually exposed. So really no significant worry. And again, this fact about women, perhaps women are exposed more often and they actually create better immunity to HPV than do men, and said that's what we see. But this is, again, actually quite a murky picture, and I'll tell you why. So just another point that what you should tell your patients, if you have a female patient and her husband partner has oropharyngeal cancer, then the female partners need a pap smear testing for sure, and then after that first pap smear, they need to just continue as a general routine pap smear testing. So that's the only thing that is actually needed. And a recent research also suggests that husbands, so women with cervical cancer, have approximately twofold increased risk of tonsillar cancer, and that also supports oral HPV transmission by performing oral sex. So it's also interesting that only 61% of all the patients actually have oncogenic DNA detected in their oral rinses, which really suggests that there is a moderate sensitivity and low specificity of this oral HPV DNA detection for oropharyngeal cancer. And partners have cleared up any oral HPV infections they may have required within 1 to 2 years. So screening challenges, and so there's your brush. We talked about this and heard a lot about cervical screening and anal screening. So here's your brush, and so here's the cervix or maybe anal canal, and you can kind of scoop up these cells, right? But it's harder to sample the lesions in tonsil. So this is a tonsil lesion, so it's sitting in the crypt of the tonsil, so you can't really have an access to it. So it's not really pap test equivalent, so that's why it's a bit of a problem. So what is the alternative detection method? There is a saliva-based test for oral HPV infection. It's now available. I don't know much about this, but it's, again, unknown efficacy to predict lesions that are actually at risk. And then maybe we need better imaging technology, but that hasn't really been developed yet. So it's really, this is a bit of an in the dark when it's in the tonsil and the base of tongue. You can't quite see it, you can't sample it, so you're a bit in the dark. So what about HPV serology? It is available. It's type specific. And as we said, 70 to 80% of the population is infected at some age, and only less than 20 of unselected population is actually seropositive. So 80% are actually have negative serology. Now, the presence of these antibodies, if you're seropositive, the presence of antibodies doesn't tell you whether you've met the virus and cleared it, so it's gone, or you have actually persistent infection. So it's not clear what to do with these results, right? And patients only develop antibodies if the virus gets into the basement membrane, but not if infection are located in more superficial layers. So again, a big question mark what to do. And not all patients with persistent infections actually have antibodies either. So it's a lot of work that actually needs to be done. And vaccination is at this stage probably ineffective, but maybe it is actually effective, depends on which vaccine do we use. So I would just finish saying that in head and neck oncology, we do hope that people get vaccinated. And so we're not only going to prevent cervical cancer and penile cancer and anal cancer, but really we're going to see significant, hopefully significant decrease in oropharyngeal cancers, but that's next 10, 20, 30 years from now, probably. Yeah, I'll be retired. I think we should, that, absolutely. So this is another argument to actually, yes, vaccinate the boys.
Wow, that was very interesting. Thank you. Any questions for Dr. Keys?
I have a family of patients that have had oral pharyngeal carcinoma, and the mother had it twice and one of the sons has died of it. Should all of those family members be vaccinated, do you think?
I am the worst person to actually ask. I sit on the other end of the spectrum. I just treat these patients. I'm not involved in vaccination, but I would say yes.
And does
that would be the most logical
pathology
to me.
report typically say if it's P16 positive?
We ask for that staining to be done, and it's usually done, but it can be false negative of just, I illustrated that example.
And in my...
It's more like the whole clinical picture, and if I really wanted to go after this, I would have asked for core biopsy, and core biopsy would have been positive, but I didn't want to traumatize the patient.
Do you see any predominance of these cancers in Scandinavians? Because in my little practice, I have 4 Scandinavians who've had this, and I sort of wonder.
I think there was one study and looking whether it's more prominent in Scandinavians, and the answer is actually no.
Thank you.
My helper to ask about the WebEx. I don't know how to do that.
There's a question over there.
Okay.
Just a question of clinical presentation with the lymph nodes. Which chain is it? Have you seen, is there a pattern, submandibular or?
It's usually submandibular and jugular digastric nodes, so upper neck, because that's really the first echelon of drainage of the tonsil and the base of tongue.
And they're fluctuant and?
They could be fluctuant. They're usually painless, and they usually kind of enlarge actually quite quickly. Some of them do have sore throat. I don't want to give an impression that this never happens. Some of them actually do have a sore throat, and there's something is kind of itching at the back of their throat. The swallowing is different that they have, but it's most commonly they don't have anything else, just nodes.
Hi, any question from the people joined by WebEx? You can unmute your mic now and ask question. Sign it again. Thanks. Yeah, we have about 4 people. Yeah.
All right, thank
Okay,
you.
well, thank you very much. I think we're going to have a coffee break now, right? Yep.
So there's coffee and tea and
So we take a break now, and we'll be back in 10 minutes. Thanks.
How does this slide? Where'd my helper man go? I don't know if my mic is on, but I can get you to take your seats, please. Turn the mic on.
Yeah, it's on.
It's on? Okay. Great. Well, I'll get us to take our seats, please, for the second half of our program this morning. Our next speaker, I have the pleasure to know professionally and personally. I'm her daughter's vaccinating pediatrician, and that little girl's really well vaccinated. Haven't given her HPV yet, but she's only a year of age. So Dr. Malhotra is a certified menopause practitioner, good to know, and a family physician with extensive training and expertise in women's health and university program development and improvement in Canada. She's the former director of Options for Sexual Health, otherwise known as Planned Parenthood. Dr. Malhotra is the creator and program director of a women's health residency training program for family practice residents here at UBC, and the founder of provincial HPV program through Options for Sexual Health. So very nice to have you here today.
Thank you, Jean. So my talk today is going to be, I'm hoping, interactive. What I want to focus on are those hot questions that come at you like landmines when people come into your office and they say HPV, and then it begins and it's like pow, 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 and you sit there going, well, why did I bring this up? And you want to in your heart of hearts, and you believe that it's the best decision for your patient, but that conversation is so awkward sometimes, so challenging sometimes, and you often get painted into a corner saying, I thought this was a good idea, and it ends up being a very difficult conversation. One of the more common questions that I hear is, I've actually never heard of it. And that is unfortunate in this day and age, but it's still happening in great array. So just remembering to step back from the doctor's shoes and remember that the general population doesn't always hear everything we're hearing in great masses. There's not a lot of media in Canada as far as medications go in comparison to the States. So at times, our patients might be a little bit behind in what they're hearing in media. So remembering to just backstep a little bit, remembering to tell them, there are vaccinations for this disease, and this is what this disease causes. So in simplified terms as much as possible. Remembering to mention that it is for both sexes and that it is really all age groups, all people. I try to make things as commonality processes for people, because when people come in and say HPV, no, not for me, doesn't apply, we have to be really clear to say it applies to everybody. It is a very similar conversation to something like HSV or just the common cold, to be honest. This applies to everyone. So we want to be really clear about that to everyone. We've already seen the slide. Being clear about the vaccines is also helpful, that we have come a long way in what we're able to offer people, and that hands down now we are doing highly effective coverage in what we are offering for people to have available to them, now having the non-valent vaccine, and how effective we are covering things. And I'm going to go through that in more detail as well. The key point in any counseling session for HPV is we can currently prevent cancer. And again, yes, if this was breast cancer, we'd have lineups out the street. If this was any other cancer, guaranteed, if this was a male-ordered cancer from the beginning, if this was started in male populations from the very, very beginning as a male disease, and we didn't bring colposcopy and cervixes and any of it into it, we would more than likely have a lot more funding, and we would more than likely have a lot more uptake to this process. But it's a hidden male disease, and it ends up falling on the burden of women. So we often get asked the question, why bother getting vaccinated if I'm getting regular PAPs? Now, this is an integral misunderstanding that the general population has and carries forward, and it is unfortunate. People in our population coming with this question fully believe that Pap screening is preventative healthcare at its best, but it's actually screening, and we have to differentiate that. It is absolutely preventative healthcare, of course, but it's not inclusive completely of what we can offer someone. So, yes?
I'd like to ask the opposite question. Why
Yes.
bother getting PAPs if you've gotten vaccinated?
Good question. Between Gina and I hope we can answer that by the end of this. So, when we talk about the division of care to the general population, we want to say we can offer you protection, we can offer you screening, and we can offer you prevention. All unique, all important, and all special in their own right. Condoms, absolutely important, not fully protective. Pap smears, vital, made a world of difference in our populations. But we know not everyone's getting Pap smears. We know that sometimes Pap smears are not perfect, and we know that we still have a long way to go globally when it comes to preventative healthcare with Pap smears. But really, prevention is a somewhat different role. Immunization is something that we have at our fingertips right now that is really prevention, not screening. It's not protection. It's all of it. It's not as simple as saying one or the other. You've seen this slide already, I know, but I did want to still bring it up. When we look at what we're missing as far as Pap smears, it is minimal. Of course, we don't have a lot of people passing away from cervical cancer I'm married to an Italian, so I say passing away a lot in my life right now. Pass away rather than dying anymore. It's a funny cultural thing in my world. But we look at the availability of access. I come from northern Saskatchewan. I come from a high volume of Aboriginal women who cannot access care easily. And I have a 70-year-old mother who flies around, who has people flown in for her primary care gynecology practice. So it's in my blood. I know these women are the few and far between in our population, but we need to focus heavily on this population. They are an important one in our province, in our country, and they are the ones that we need to be really passing on education to in strong and high numbers. Because although we have a wonderful Pap screening program for our woman in Kitsilano who comes every month wanting another Pap, we have to be very aware she is not our typical patient that we're talking about today. So remember to focus on prevention. Now this also goes to that woman that comes in from Kitsilano who says, I'm taking this vitamin and that vitamin and this vitamin and that vitamin to prevent everything, and wonders why you don't know about all of this. And you say, well, I do know about one thing that I can offer you for prevention that's very safe, very effective. And this is something that you can pull out and say, this is what I have for you. When someone says, I don't know anyone who's had cervical cancer, and should the government be using my tax dollars for vaccination? Now, this is a hot and heavy topic. A big reason is because of what's happening in Ontario. Has anyone been following what's been happening in Ontario? Our doctors in Ontario, our colleagues, are going to be suffering clawbacks in April. So they're going to get paid for the rest of the year and then have to pay back part of their payment from January to April. We don't know how much, we don't know what's going to happen, but it's to balance the health economy budget. So big deal, and it could happen in any of our provinces, but that is what's going on. So when we talk about what's happening with our tax dollars, how can we use it most effectively? Diane's already touched upon the fact that we spend a lot of money on colposcopy. We spend a lot of money on Pap screening. Could this be something that we could reevaluate? Could this be something that, yes, do we need to be doing so many Paps? Do we need to be screening these women on the rates that we are? In the future, maybe not, because what we could more effectively use our tax dollars potentially for is preventing the illness that this happened already, that this is leading to. It impacts a lot of women, there's no question, men and women. We see a lot of warts, we see a lot of dysplasia. Although we don't see a lot of cervical cancer and not high volumes of numbers are coming out of cervical cancer, we do see a lot of the other morbidities surrounding HPV. So they're high enough numbers that we are spending a lot of money towards. In British Columbia, for example, each episode of treating genital warts is around almost $600. So it's a lot of money. When you think of where the money is coming from and how it's being allocated, it's definitely something to be thinking about, because it's hundreds of millions of dollars per year. When we talk about how we could reduce costs to our system, really vaccination is the key in this particular circumstance if we wanted to talk dollars only. Vaccination in one study was actually shown to decrease our spending dramatically. So when we're spending $28 million on certain services to do with dysplasia treatment and management and HPV management, we can drop that down by vaccinating 20 or 30% more of our population by almost $20 million. So it's a lot of money. So we're talking a massive reduction in costs if we were vaccinating our population. When we look at the visits, when we look at the treatments, when we look at the repeat visits, and when we look at the specialty visits. And that is a government-funded program. When we talk about counseling, again, you have likely known someone who has had HPV. It is something that we want to reiterate to patients and parents. Anyone can say that. It's, of course, a touchy topic. We want to always be careful of what we say and how we say it to whom. But we want to reiterate to them that it does make financial sense to be vaccinating. So currently, we have a minimal number of people accessing the free programs. Not only do we offer it to very few people, but very few people are actually getting it within those programs. But if we were to increase the number of women, if we were to double and triple and quadruple the number of even just half the herd women getting the vaccine, we would more than half the costs to the system by including the payment of the vaccine within that cost. That's remarkable. What can we say that about? If we were to spend just a little bit on these, that we could dramatically decrease the healthcare budget. It would be pretty special. Because we hear that a lot.
Mama.
So a sideline conversation, I get asked a lot. I'll have the mom and I'll have the daughter as the patient. I'm in women's health, for those of you that don't know, so I see the whole gamut. And someone will say, well, I'd like to get my daughter vaccinated, or I'd like to get my son vaccinated, but I don't think this actually applies. And that is sheer denial, as we all know. And how do you broach a topic about that? It's very, very hard. One of the things in the back of our mind that we should keep in place is something that Tin has brought up already. This is a Canadian study. It's the Pisces study that was done. We have a Canadian arm to it. When someone gets the result of having an abnormal pap or genital warts, there is documented clinical anxiety and documented progression of that over that diagnostic period of time to that person receiving that phone call. So it's really important for us to bear in mind that even though you might not think it's going to impact them, or they might not tell you that it's going to impact them from child to mom or dad or whatever the circumstance is, it's more than likely going to impact them negatively. Their future sexual behavior, their personal self-esteem, and of course, everything that comes with that. But it is documented that that is really impactful. When we look at the Pisces study, it's nice to see that this is a Canadian study. Although small, it is still important. We look at how long the issue lasts for the patients, and because genital warts episodes can last on average over 100 days, that is a long time for someone who's burdened with that anxiety and all of the things that come with that, the feeling of self-worth, all of the self-esteem issues that come with it. They're really important to bear in mind. And that's something to pass on to the parent, to the woman and man in your office, to say, you might not think this applies to you, but if it did happen, mental health is a big part of what goes in this disorder. So it is not just that we are treating the warts. It is not just that we are treating the cervix. We are also encompassing with our prevention and treatment the self-esteem and everything that person embodies about sex going forward. We want someone to have a healthy sexual attitude and a happy sexual life going forward. And if they say in their mind, my child's going to have one partner, they're going to have sex twice. They're going to make 2.5 babies, and they're going to move on with their life. In their head, they really believe that. I have a daughter. I believe that. I tell my husband all the time, she's going to have sex once. So it's ingrained in your DNA. But we also have to think, well, what if that partner came into the relationship and they hadn't had sex the one time, and they brought in the HPV, and then they got it? Okay, so be it. We're doctors. We can figure it out. We can do it all. But maybe they're mentally and emotionally traumatized about what has just happened. Maybe they've been traumatized by a colposcopy visit. Maybe they've been traumatized just by the repeat PAP that we take so lightly in our offices. And that's a big reason that there is a promotion not to have, not only the cost and all that we're doing, to having those young girls come to our offices and have these repeat PAPs and have all of this done, and the risk of having the younger population go through that and trying to start later. But it's important to remember that that carries through for decades down the road. So we want to keep our young people happy and healthy and safe emotionally as well as physically. So another question that we get asked, my friend had warts and they just went away. Very common. That does happen, absolutely. But again, a lot comes with warts diagnoses, and a lot comes with how long they last, and a lot needs to surround our counseling and our ability to talk to people about this. So again, self-image is a big part of this. We want to be very cautious to make sure that people are trying to get the best health and mental well-being that they can have. Absolutely, they may not stay around long, they may go away on their own, but isn't one day enough for someone? Like, how many times have we had people come in our office and it's something very minor, and they've been calling and calling and calling all morning long to try and get in for your urgent slot that you had available for someone that really, really, really needed it. And it was something to them that felt very important, and to you, it's like on the triage list, maybe not. But it's, again, we need to validate what's going on. And if we could have prevented that phone call, if they could have prevented that phone call in some way, and that day of anxiety and stress, wouldn't that be a good thing? I think it would be. And here's the big one. I've heard bad things about the vaccine. We all know that. We know the vaccine is safe. The global safety data is there. We've all seen it, we've all heard it, and we all know this. But even my mommy group is all doctors. All doctors. We had a discussion not that long ago. Is the hype real? Is the hype not real? And it was so interesting to see. We're all various specialties, so absolutely some pathologists in our group were like, I don't know, and that's normal. Like, how can you know everything about everything? But it's very confusing, and media is very good at what they do. So to twist and turn, especially since in Canada we get it secondhand very often. Something happened in the States, and then it trickles over to Canada, and so it gets even more confusing and more jumbled. So yes, the vaccine is safe. We have global safety data. We know that, yes, some people will pass out. It's happened in my office. It's happened in all our offices. Yes, vaccines hurt. My daughter screamed her face off at Jean's office the other day. Vaccines hurt. But very few people are going to have a real issue with any vaccine that we have on the market in Canada, especially one that is tried and true, like HPV. The tolerability of the newest version of the HPV vaccine is comparable to the others, so as safe going forward can be assumed. But then we ask, well, should I even bother? Is it even going to work? We all know that it's going to work. We know that we're achieving great efficacy with our vaccines, and it's passing that information on. Something that I find helpful that we've all brought up today is the Australian data. But a lot of people that have heard me speak before or spoken to me before know that one of the ways I like to bring this into my clinic is saying, like everyone knows, an Australian, we're in Vancouver or Whistler, likes them. They're a country like our own. It's not like you're saying, well, off in some far-off land, they're giving vaccine to everybody, and they have no problems and no disease. And they say, where is this magical land Well, it's actually Australia, which is great because it's a comparable population that I think people feel a degree of camaraderie with. And if Commonwealth does nothing else for us, I think that's something great. But it helps. If ski work visas have done nothing else, this is helpful. We do know that the vaccinated population in Australia is doing very, very well. The numbers are petering out, and they can eradicate disease in our lifetime, which is pretty amazing. We do know that when the program began, no one knew what was going to happen, and the numbers that were so dramatically great really were quite a surprise to everyone. I think even Gina would have been surprised by the numbers. And, to happen so quickly, to see a decrease in disease within 6 months of a vaccination program was remarkable. Yes?
Were they using
Gardasil.
Cervarix as well? Or?
Gardasil.
Gardasil, okay.
Yeah. Really, all programs are at this stage. I believe the UK did for 2 years use Cervarix and then dropped it. Because the results are just so dramatic. And I don't want to diss on Cervarix. Cervarix did a great job at certain things, cost being a big part of it. So if someone had to get something, get something. But when we know now, especially having a vaccine like the newest, the 9-valent, where we can say, there is a tremendous difference in what we're offering someone, we need to keep that in mind. And that comes down to our standard of care.
Wasn't our government, though, giving, maybe I'm confused, weren't they giving Cervarix to people
Just
in
the
schools?
one-time program, not schools. That catch-up program, that one-time program, that was Cervarix. And that was cost. It came down to how can we get more people vaccinated. And absolutely, cervical disease is the disease of choice. So if we can get a cheaper version of it for needed times, it was necessary. But in the end, Gardasil is hands down going to provide the coverage that we need for warts, and Cervarix isn't. So, does that make sense to you? Okay, go on. Oh yeah, no worries. So again, just highlighting the Australian numbers and highlighting to people that this vaccine is working and it's safe. And globally, if this vaccine was truly as dangerous as we've heard from Katie Couric and others, Australia would have probably alerted us at this stage, and we probably would have. So my goal today is just to embrace the practicality of these conversations that we're having with people and make it very clear that it's working, it's safe, it's being used everywhere. It's been used for a long time now. It's over 10 years of data. We have to really believe it. And then it's going to work for what it's intended to work for. It's not going to treat your foot fracture, but it's going to treat your cervix very effectively. One question we get a lot asked in our clinic is, I've already been diagnosed with HPV, so I don't need it. That is one of the most common things I hear. Not only do we hear, well, I'm getting PAP, so no big deal, but, well, and I had an abnormal PAP, so why bother? I already have HPV. And that's an important moment in time to tell someone, you have HPV, but there are multiple different kinds. And that's an educational point that doesn't take very long to counsel to, but just making someone aware of the fact that, yes, you probably had one strain, but the likelihood of you having all of the strains that are covered in the vaccine is highly unlikely. The original WHO paper that came out, gosh, now we're probably talking 15 years ago, in fact, in small print, on probably page 12 or so, the ones that took the time on Saturday night with our glass of wine to read it all through, had a moment in time in it that could have been highlighted much more effectively going forward, which said straight out, if you had HPV of one strain, you are still a candidate for this vaccine because you're unlikely to have the remainder of the strains. And that got lost in translation over the years by health professionals, by the general population, by everybody. And it's something we need to bring back into the discussion. And that's why at colposcopy clinic, you are now walking out with a prescription. The Patricia trial is one that highlights that very point, that our vaccinated group does better going forward even after abnormal PAPs. But this trial I really like. It's a small trial, the Kang trial. I know I bring it up a lot, but I like it. It's an easy trial to understand, where we had the patients who had leaps. So CIN 2 and 3, what do we do with those patients? So these are the really questionable patients in our practice. And what was interesting is the recurrence rates going forward in the vaccinated post-leap versus non-vaccinated post-leap patients. And you probably can guess, the vaccinated post-leap population did much, much better going forward than the non-vaccinated post-leap population. And King, in fact, came out and said, no vaccination after leap is an independent risk factor for recurrence. That's a really bold statement, but a really important one. So can we prevent this girl from going back to colposcopy? More than likely we can in many cases. So that's something to bear in mind. So when my patients come back to me after their colposcopy appointment, I like to have a very detailed HPV-focused visit. So I bring them back for a special visit just to discuss going forward and what that means. And I think that's important. So it's all the more reason to be talking about the vaccine at this stage. I'm too old for the vaccine. 25-year-olds in my practice are saying this to me. So keeping a copy of the NACI guidelines in my office is helpful, showing everyone it's not just me, I'm not just some crazy vaccine lady coming at you with all of these recommendations. NACI is going to support that up to 45, we have really good data. And off-label, you can go past that. There's no question. I have a menopause practice. I'm still vaccinating a lot of my women in my practice. Off-label. We have a discussion. We know what's happening, but I think it's important. A lot of them have partners who have either passed away, or divorces, never a partner, all kinds of new circumstances. And I think it's important to have the same discussion with them. Yes?
So recently in the talk about that, and there was suggested that even if you get cancer and you were vaccinated, yes, that you are somehow more likely to benefit from treatment. Yes. Do you agree with that?
I do.
I was not sure, but that was stated. So
I do.
That would be another thing to actually convince people, right? So even if you get it, you have better outcome if you need treatment.
Yes, absolutely. That's absolutely correct. What I find remarkable about HPV, you've seen us sitting here and all of us are talking to each other's talks and very similar information is being told to you. And all of us are saying the same thing. There's still a long way to go in our knowledge of HPV, but what we know for sure is vaccination is only going to cost you the price of the vaccine. So going forward, there's absolutely no population that I would say, probably not for you, unless they were actively pregnant. And that's really it. And that's because we're not going to touch those ladies. So we're going to stay away from those ladies for everything. Really, age is but a number. And 45 is young. Like if we think about it, when we're 45, what's going on in our lives, that's a young person. Like 45-year-old women are coming into my office hoping to get pregnant at this stage. So, it's a totally interesting, arbitrary number in many cases. It's really based on how much data we have at each segment of life. You have heard about the vaccine protecting against more than one subtype. I do recommend not promoting the cross-protection data. It may happen, it may not happen. Just promote the vaccine for what it is meant to be promoted for and authorized for. So reiterating just the guidelines that Health Canada puts out, it's easy to keep these as a little chart on a wall in your office for people to read while they're waiting to see you, and then they can bring it up as well. Will I need a booster? We've discussed this earlier today. More than likely not. We're at just over 10 years now and still doing well. We don't have breakthrough cases, and that's what's going to tell us whether we need a booster or not. So we've got great immune memory. So we can't promise, but going forward, you're okay. Can I get another vaccine? I, as Jane knows, like to give as many vaccines as possible at one visit to my child. So arms, legs, whatever, will wrangle her down and wrestle her to the ground. But it's important to know that it is safe. You can concomitantly give more than one if that's what's happening. What are our patients hearing? Many things. Most of them that we are the devils when it comes to vaccine and we are all paid out of pocket by pharma. and that we are promoting it and making it in our back rooms and selling it for whatever we want. That's the bottom line of what's happening on Facebook. So we have to recognize the validity of that to people, in that many people, that's their news. They get their news outlets from Facebook. Gone are the days of pulling up a chair to watch Peter Mansbridge with your family and say, hey, that's the news. That's gone. Your Twitter feed and your Facebook scroll, that's your news. That is where you get valid medical information these days. So we have to be very careful to dance around it, because it's insulting to say to someone that's crazy when it is. But that's what someone's hearing, and it's on massive influx. The feeds are updated by the second, by anybody at all. Any author is now a reputable journalist. So we have to be really, really careful. Donald Trump is a doctor all of a sudden. You know, to say that I am now questioning not only every other normal thing on the planet, but I am also saying that the doctors are big fat liars. A presidential candidate in the lead is saying this, and celebrity goes a lot further than we do. And when you see there's a physician running for president now who also said something very, very similar, a neurosurgeon. And it made me very sad to see that you have now turned your back on your profession to get votes. And that's scary and really, really important to not be president, and really, really just sad. So to bring back these autism fears and what the doctors are doing and how much money they're making off of us, when I don't think anyone here is going to be ordering the brand new Tesla anytime soon in this room because of the money they're making off their pediatric and GP patients. But we're trying our best, really, just to get through the day and do the best we can. When counseling, we do want to offer some reliable sources. So diversion is a good method. It's often the only method. So saying, yes, I validate where you're getting your information and what you're hearing, but these are some sources I trust, and this is where I'm coming from. Something I do in my menopause practice as well, where we say, I understand what you're hearing, but this is what I practice. And that's all we can do. We can just keep our backbones. We can just keep going in our own right and go forward as we can. So there are a lot of great resources available to people, and they're Canadian websites or global websites, which is really good and easy to navigate. I find them very straightforward. When we talk about our boys, what to do, not only do we have the issue of coverage, but we also have the issue that we all know we don't see them. So they come in with their moms, and then we've never seen them again. And that's difficult. So the approach that I'm taking in my clinic, and the floor is open, is to hopefully have the woman in their life try to navigate it. If it's a sister, or if it's a sister-in-law, or a mother or grandmother, to give them the Kool-Aid to give to the boy. And so I don't know what you're doing in your program, in your clinics that has been successful. That has started to work, where people have asked, where does he get the prescription? I will make him do it, kind of discussion. I will at least bring it up at the dinner table. I will at least go forward. If there's anything else that's working for people, please, the floor is open. So it's a tough one. The things that we can do is that we need to be a team. We need to have a strong front going forward in medicine. It's really important. We need to be verbal. We need to bring the conversation up as much as we can. Every time we see someone, we need to be bringing up the things on an ongoing basis. You can't bring up everything at every visit, but serially we can get through it. Being confident with our message. So when we're being painted into that corner and they're saying, but what about this and what about this, and they pull out their phone and there's Donald Trump's tweet and whatnot, be confident. Stay strong, sister. Like, it's important. We don't have a lot of media coverage that's positive. So as visible as we can be, the better. So signs and whatnot in your office are important, because the doctor's message is still going to resonate to some degree. They can say yes or no, but it will be heard and felt at some point in their lifetime, which is good. They will know that we mean no harm and that we do want to help, which is good. But it's really just that positive message and being very confident in it. Questions?
Boys are not getting it in school, are they?
No, they are not. I believe Alberta, PEI, and is there one other province?
Scotia?
Nova Scotia. Nova
And
Scotia.
Is anybody working on that?
Yeah.
There's
Yeah.
one.
The hardest working woman in medicine is sitting right here. We're very lucky to have Gina here today because although we're fighting the fight, she is fighting the fight 24 hours a day. And there are a few people who work harder than she does in medicine in general. So we're very fortunate.
You talk about that yummy mummy from KITS.
Yeah.
But she may be on supplements, but she's less likely to get her daughter to get HPV vaccine.
Absolutely.
There's a negative correlation between
She'll buy her
economic status.
condoms and leave them in the jar at the front door, but no vaccine. Like, it's a real dilemma of thought.
HPV will not cross over Maine, right? So
absolutely.
I have a question.
Yes.
Has anyone figured out why the Fraser Valley is so low? Because if you look at the actual individual schools, like I thought it would be a lot of the religious schools, but there's low rates in a lot of the public schools. So is it a religious thing? Is it an economic thing in that? I don't know, I find a lot of the West End or the well-off are the ones that are really even more anti-vaccine versus the very poor people who come from third world countries. So any idea why they're so low?
This is semi-opinion. There is an issue with my experience in the Valley, with cost, with education, with the translation of media forward and what is being heard and felt and understood. There is a severe physician shortage for primary care physicians to get to the patients. And there is a severe lack of public health in schools. So there's multiple factors. I don't think it's one thing that we could pinpoint and say that's what it is, like we tried to do with the Bible Belt scenario. That's really not completely correct. But there are multiple factors that lead to this storm that happens. And it happens to be this pocket of care. It's not the only pocket in BC. There are other pockets. But it's a misunderstood area of care. And I think it does translate a lot to education in many degrees. A lot of third world countries will do anything to keep their baby alive because they've seen death. So it's very different. Like my mom runs a cervical screening program in Delhi, of all places. And in that program, all she's doing is buying pap slides and training a nurse. That's it. And they will come in droves, because they've seen people die. We haven't. So there's that. So it's an unfair comparison, I think, between the third world and our population because we don't see death. If someone gets sick, they're unlikely to really pass away in the same degree and in the same circumstances as a third world country. But our yummy mummies and kids, that's a whole other beast. Like that's a whole different scenario where they can access care almost too easily. Like there's almost like a drop of the dime type of scenario where they can get private care. They can access their physician 24 hours a day at times. And maybe that's not a good thing all the time. So each scenario is probably different. I don't know if Gina would agree, but I think each one's a different case. So, yes.
Is there any data with a 3-dose series, how much protection you get after the first dose?
I'm going to leave that to her.
Oh, okay.
Awesome.
Okay, and WebEx questions?
Hi, people joined by WebEx. Do you have any question? No. Okay. Yeah.
They all went for coffee.
Thank you.
Okay.
Thank you.
Thank you very much.
Thank you.
Very interesting. So our next speaker has a very long list of accomplishments here, but I'll just get the high points. So Dr. Ogilvie completed her undergrad education at Queen's and then McMaster, did a family practice residency at McMaster, then a fellowship in population primary care at McMaster, then came here and did, where did you go then? Oh, master's in UBC, and then a doctorate in Northern Carolina, Gillings School of Public Health. Her clinical and research interests include women's health, care of marginalized and at-risk populations, reproductive health, sexually transmitted infections, HPV screening, and the HPV vaccine. She's certainly very widely published in these areas. Gina is now Canada Research Chair in Global Control of HPV-related disease and cancer. And she is principal investigator of the HPV Focal Trial, a randomized trial covering over 30,000 women to examine HPV testing versus cytology as a primary screen for cervical cancers. Thank you for coming this morning.
It's great to be here. That was a great presentation. Thanks, Anjali. That was wonderful. So just quickly to answer the question about one dose. So the data is not, there's one study from using actually Cervarix that really looks at a single dose, and it actually offers some protection. But there are actually now planned about 3 trials globally to look at a single dose. So I think, that is likely where we're heading, to single dose of the vaccine. So, and potentially even single dose at 11, and then single dose at 25, and if it's doesn't sort of achieve the sort of immune level we want, and then you're done. So it's a very exciting time, for sure. But for me anyway, it's exciting. For others, it's whatever. I think you guys also nailed. I do want to be really clear. The sense that you guys have that the more educated you are, the less likely you are to get vaccinated is spot on. That definitely came out in our analysis of women when we looked at parents of kids who received the HPV vaccine in the province. So these were actual people who got the vaccine or not, and one of the biggest predictors was socioeconomic status inversely. So the more educated you were, the less likely you were to receive the vaccine. I think there are a couple of things in that. Google University, people feel they can go online. I do think, physicians, often we fall into this. We're smart, we're book smart at school, so all of a sudden we think we're great financial gurus. And that's why there's MD management, because so many physicians lost so much money in the markets. But, hey, we're smart at school, so hey, we must be able to do that. So I think it's the same thing in other ways. I have a lot of parents of children I know who, they have a PhD in history, and so they feel that allows them the same level of expertise, and they are very smart, don't get me wrong, but they feel the same way that physicians felt our knowledge translated to our ability to be sort of market gurus. Same way they feel their knowledge allows them to be, science, leading scientists. It's the same sort of mismatch. And I think the other thing, actually, to be honest, is I think people who are wealthier feel control. So I don't need to get it in grade 6. If I choose to get it in grade 9, I'll take my child to the public health nurse, or I'll pay for it. I don't need to be managed by the public health system. So I think there's a couple of variables, but I do think the most dangerous one is folks feel they're able to do their own research, and we know what it is like online. So you're spot on. So today what I wanted to do was give you guys, when we talk a little bit about PAP screening, I want to just talk a bit about the future of PAP screening. As people who are focusing on care of children and pediatrics and adolescents, I think the bottom line for you to know is that as we move forward, PAPs will be less and less of an issue, certainly for youth and likely for women. We will be sort of transitioning to a whole new way of screening. But I think it's really important to know that the two dovetail together, and that there are factors, particularly the HPV vaccine, but also the technology we're using will actually now change also the type of screening we do. No conflicts. So you guys have all seen this, and I think the big thing that is important about the natural history of cervical cancer is we ultimately would love to protect, and Anjali talked about the fact that people say, well, PAP screening is good, but the best thing obviously to do is prevent acquisition, so that's why we want to work here. But PAPs work here, where we want to detect precancer. And I'm going to talk about, hopefully, where we can detect here with HPV infections. Interestingly, as good as PAPs are, there's actually never been a randomized trial to show that PAPs work. They were introduced as a sort of a smart move, but they've never actually undergone a clinical trial. So I always find it very amusing / depressing when you do read those sort of op-ed pieces where people say, well, PAP screening works great and there's good rigor in PAPs. I agree that Pap screening worked. Here's some great data from the UK showing that once they had an organized program, we saw a reduction in cervical cancer. But let's be clear, the rigor of Pap screening versus the rigor of HPV vaccine actually don't match. HPV vaccines have been far more examined. We have far more knowledge about adverse events from HPV vaccine than we do from cervical cancer screening with PAPs. This is not meant for you guys to delve into detail, but I think what's important to note is that there is variation across Canada. It's the joy of our Constitution that gives us a public, that puts healthcare in the hands of provinces. So we do have differences across provinces. The big thing for BC is to know that our current PAP screening guidelines are that they start at age 21 or within 3 years of sexual contact. That's been a bugbear for many of us, but theoretically, right now, if a young woman is sexually active at 15, she should be having a PAP at 18. I do want to flag for you that will likely be changing, but that's where we're at right now. So what's the future? Well, to be very honest, the future is HPV screening. So this is some data from pooled studies from actually Finland, some places in Europe and in Montreal. And what it shows is that when you have screening for cervical cancer that includes an HPV test, this is not exclusively only an HPV test, but includes an HPV test. When you follow women, using that HPV-based screening reduces not precancerous lesions, not colposcopies, but actually reduces cancer. So when you actually include an HPV molecular test in the screening, and it prevents about 30% more cervical cancer than cytology. So it's a very important finding. This was a pooled meta-analysis. And there's the data just showing again that the reduction with arms that included an HPV test. So this is what we likely will see in the future for cervical cancer screening, which is we will start between the ages of 25 to 30. And again, I want to give you the global landscape just to remember the UK starts at 25, Holland, Netherlands start at 30. So our programs in Canada start much, much earlier than other jurisdictions. We will, yep.
Hasn't the Canadian Preventative Task Force said 25 as well?
The task force has, but that hasn't, no province has actually used that. And there's some debate too from the task force because they were reluctant to push for HPV screening, and so there was a lot of hesitancy around their findings on that as well. Yeah. So where we'll likely see is we're going to be moving to a start age of 25 to 30, 20, depending on how comfortable health agencies feel, maybe 21 and 22, maybe. But if it's HPV based, it won't start likely till 25. 25 to 30, going up to 64. We will see an extended, so that's a big thing for if you have a youth practice. You won't routinely be offering cervical cancer screening. And remember, screening is for asymptomatic people. If a young woman has symptoms that you're concerned about, bleeding PV, etc., you're still going for your diagnostic assessment. So let's make sure we're really clear that screening is for people who are asymptomatic. So, and in those young women, in those women who get a screen and are negative, so normal, we probably will extend out the interval to 5 years. So a very different approach than many of us are used to with the annual or biannual PAP. For women who are positive for HPV, we'll likely do what's called some type of reflex test. And I won't go into all of the details of that, but that will be done at the lab. That's not something women will need to come back for. And it'll be an additional test to help improve the specificity. HPV tests are far more sensitive than cytology, but they're much less specific. So what that means is there's an issue of actually iatrogenic illness. We may be over-identifying certain women who don't need to be followed for colposcopy.
Would this be a blood?
No, so this is all on PAP, all like the PAP smear. It's sort of like taking an STI test. So what we'll do is a reflex test, whether that be a molecular test or on a liquid-based specimen, just a cytology. And then those women who are HPV positive, cytology positive, they'll go on to colposcopy. Women who are HPV positive but cytology negative, they'll go into a more frequent repeat screen so we can monitor if they start to develop persistent infection, precancerous lesions, etc. So I just want to give you this, sort of a work in progress, I would say, but just so you have a landscape of where we're going to be in the future. So one of the big things that I just mentioned to you that we had that big meta-analysis that looked at HPV based screening, let's call it, so screening that had HPV. In BC, we took the step of actually doing a randomized trial comparing just HPV screening. So not HPV with a PAP. We just did HPV screening and compared it to cytology. This is called the HPV focal trial. Just so you have a sense of it, we are looking actually for CIN3 at year 4. And I know everyone's saying year 4, but you said it was going to be a 5-year interval. I do have to tell you, this field really moves rapidly. When we started, you can see the next objective, our ethics board said, we think 4 years is too long, so you need to put in a 2-year arm. So from then to now, where we're getting criticized, oh, you should have randomized a 5 and a 10-year arm. So it's very interesting how even in a very short period of time, the field has moved so quickly. So our main endpoint is looking at precancerous lesions in 2 arms at year 4, post-screening. So it's a large trial, about 33,000 women, and then we have an initial round and then a second round or third screening round, depending on their arm. CIHR funded, and funding was approved for 7 years. We've long spent all that money, by the way. We're getting other money. So the big things I want you to look at here are the control arm and the intervention arm. Don't worry about the safety arm. The control arm, women get cytology, and if they're negative, they get a cytology at 2 years, and if they're negative, they get a cytology at 4 years. The intervention arm, women get an HPV test, and if they're HPV negative, they don't get tested for 4 years. And that's what we tried to do, was mirror what we thought the program would look like. So this is all embedded in the cervical cancer screening program. These women have all of this data within their cervical cancer screening history. So that was really important. So that's the main outcome. If women are abnormal, I won't go through it in detail, I'll just show it to you. There's an algorithm that we go through, whether they go to colposcopy, etc. But the big things for you to know is this. We're comparing regular cytology at 2 years and 4 years for women who are negative compared to women actually getting a screen every 4 years. So we've got 25,000 participants enrolled, 18,000 have been discharged from the trial, about 500 have been discharged because they actually had colposcopy, and we anticipate all screening will be done by December 2016. So just a very busy slide, but what I just want to show you is that the round 1, so the first screening, not surprisingly, HPV detected more precancerous lesions. HPV we know is more sensitive. We're not surprised. We detected more precancerous lesions. And that's both in under and over 35-year-old women and overall.
That's really delicious milk.
But HPV screening resulted in almost double the amount of colposcopy referrals. So we do have an issue that we're going to have to manage, which is that we have more colposcopy referrals, and so we'll need, probably what we need is a better test to discriminate HPV positive women who truly need to go on to colposcopy versus just sending women who are both HPV and cytology positive. We probably need something else to help us be a little bit more judicious in that. And we're excited because this has been named one of the most important sort of trials for cervical cancer screening globally, and will be helping to set the stage not only for Canada but for the US, who, as you know, have a long history of way over screening everyone for everything, and so they're really looking forward to sort of getting some really rigorous data to show not only whether we prevent cancers, but what the iatrogenic consequences of over-screening are, and are we actually doing harm to women if we, for instance, too frequently screen them with HPV. So I wanted to really focus for this group a bit about the age under 25, and how many of you have youth practices where you're doing youth clinics, or are any of you in that group? And yeah, Anjali is. Yeah, so this has been actually quite a concern, I find, particularly for the public health nurses, more so than some of the practitioners, but particularly the public health nurses who've worked with youth clinics, the sort of 15 to 19, 15 to 20-year-olds, and many of the nurses who've been doing this for years. And we all have seen a CIN2 in a 19-year-old. I mean, if you've practiced long enough, we've all seen it. Now, sometimes I feel like it's the same case that we've all sort of helped to manage, because we all manage in teams, but we all have seen that. And so there has been a lot of concern brought forward to me about, what about this under 25, that we're not screening women under 25? And I think we have to be really careful about what screening is. And remember, we're screening to help us improve detection and ultimately improve the outcome. Just because you detect something doesn't necessarily mean you improve the outcome for that young woman. So we all know about lead time and length time bias, and those are really important in this age group, because if you go all the way back to that first slide I started with, remember the natural history, right? You acquire HPV, then you develop a persistent infection, then you develop a precancerous lesion, and then you go on to cervical cancer. So there is, by and large, a long natural history. So whether we detect it at 19 or 25, the risk is that many of those may have regressed, and that is a natural history consideration, that these lesions do regress. So are we over-screening these women? And then particularly in young women, and many of you will remember this, when you do a PAP in a young woman, I mean, the sort of transition zone and the metaplasia is just massive. So if you send that woman to colposcopy, what happens as a colposcopist, we're taking out a huge chunk of their cervix. And there is data that shows that if you are doing LEEPs and excisional procedures in younger women, it is associated more with preterm labors and low birth weights. And that, makes sense if you don't have the same type of tissue present. So we have to be super careful that not only are we detecting what we want and preventing what we want, that we're not harming these women more than we intend. So let me just show you some of the data. This is always the stark sort of reality, and to Anjali's point about parents and the HPV vaccine, I have about 3 vignettes in my head of a nurse who I worked with who was very interestingly anti-HPV vaccine, and she was telling me all her reasons. And, I take the stand like you of listening and of saying, that's not my experience of the data, and I try to articulate it. But I also feel that it's important to not close the door, so I leave a very open sort of dialogue. So she shared her thoughts with me, and I gently disagreed and said, here's why I don't believe it's right. But she had a 15-year-old daughter, and she wasn't going to get the daughter vaccinated. And I said, well, isn't it great we're in Canada and you can make that choice? What else am I supposed to say? Super. I didn't think that was a long-term solution. Jane's suggestion was I say you're an idiot, and I'm like, oh, well, I know how Jane practices. I know that never happens either. So we all think it that way. So I just left it, and then, we're chatting, and it was the weekend, and okay, have a great weekend. And I swear to God, I'm not kidding you. On the Monday. So just remind me, if my daughter missed it in school, how would she get the HPV vaccine? I was like, well, that's curious. You go here today. She didn't know. Her daughter had a boyfriend for 6 months. They had been sexually active for quite some time. And it was this boom. And it's back to that point of, and it was all of the rise above, noble, good person you are. Oh, let me help you. And yes, it was all I could to not say I told you so. But that is, so I'm telling you guys, I told you so. I wanted to say that for so long. But I think it's not an uncommon experience. As the parent of teenagers, I get it, right? There's a whole world that I'm not part of, and that's the nature of the beast. And so, I think when you're sort of at the population level, you can understand that, 30% of 16-year-olds are sexually active. Like, that's the data in BC. That's the data. And by 19, the vast majority have been sexually active. So that's just the data. So I do think, and this is the data that confirms that. If you look, these are young women who presented for reproductive health, and you can see the prevalence for HPV it's almost 35% in women 20 to 24. I mean, it is very, very high. But remember the natural history. Most of these are going to resolve on their own. And here's the mirror of it. So we have, here are the cervical cancer rates, actual cancer rates in young women under the age of 25. And you can see these rates fall well below, particularly for under 25, what would be the justification for any screening program. Okay? So we have to be really, so remember, a screening program, and this is the harsh sort of conversation, a screening program doesn't promise to find every case. It promises to find most, right? And so we have to be careful we don't design a program to find every case, because if we do, we will do harm to those women who shouldn't be in it. Yeah.
Could you on that sort of vein comment on doing PAPs in women over 65, which many countries don't do?
Yeah, so it's the same. So we will get, so the question was about doing PAPs in women over 65. And again, Canada's in this really interesting, because we do have more European sensibilities, but we're proximate to the US. So we have this bizarre kind of where we're influenced. So a lot of our healthcare practices are influenced more by the US. Like you said, in Europe, a lot of the countries actually don't screen after the age of 65.
But I'm actually an American doctor, and we stop at 65. I don't understand this Canadian 69.
So it depends on which guidelines you look at. So ACS says one thing, ASCCP says one thing, US Task Force says another thing. So this is, and most of the specialists lean to whatever they don't go to US Task Force, they go to whatever their specialty journal says about it. So in Canada, we have continued to 69 because one thing is our immigrant population. So we have a large number of our cases in the 70-year-old cohort are actually women who actually haven't been screened all the way along. Anja, you talked about the sort of, and if you look at BC, for instance, our two largest immigrant populations are from Asia and South Asia. Many women will arrive having never been screened. So what we have to do, where our guidelines will go, is we will stop likely at either 59 to between somewhere like that if a woman has 2 to 3 negatives on record. That's going to be the key. So they have to have negatives. If you don't have negatives, you keep going. And certainly you have to also remember in the future, our women who are immigrants as adults will not be vaccinated against HPV by and large. So they're going to need to keep screening. It'll be based on frequency of screening. So that's one thing to sort of reassure you. And let me be clear, I suspect when we go to our HPV-based guidelines, we will likely still allow women under 25 to be screened, but it will likely be done with cytology, I suspect. So we'll start HPV at 25 and sort of offer, I don't want to say offer screening under 25, but it won't be turned away, if you know what I mean. Yeah. And here's the thing I think that's really important for you to look at, is you can see that regardless of the presence or absence, this was from Finland, regardless of the presence or absence of a screening program, there was no change in rates in cervical cancer in women 20 to 24. So Finland didn't have a screening program, then it had a screening program, and you can see that throughout the entire period of time, the 20 to 24-year-olds did not change. So that's really, we're not, for those very rare cervical cancer cases in that age group, PAPs are probably not the way to diagnosis, and neither is HPV. They probably just have a very unique natural history. So I do want to just, I know I've got a few more minutes, I do want to end off with just a few comments on, remember the difference between screening and case finding, and if someone has symptoms, they need to be screened, they need to be assessed. Women still need reproductive health screening, and particularly for adolescent women, 13 to 25, they still need their STI screening, their reproductive health, their contraceptive counseling. So you don't, just because you're not doing a PAP doesn't mean those other things don't need to happen. And we need to support access and uptake of particularly reproductive health screening and ongoing monitoring as needed. So what are the implications for HPV testing for clinicians? I think I've just showed you that strong evidence is accruing that HPV-based primary screening will detect more precancerous lesions. The increased sensitivity will result in less frequent screening, a later age start, and earlier finish of screening. But the poor specificity will result in increased colposcopy, likely at the start of the program. I think some questions for clinicians is how do we continue to engage women in routine care? And, you know, one of the things I remember when we transitioned, it used to be when I practiced, we wouldn't give women oral contraceptives if they didn't have their PAP. And then all of a sudden we realized that's like totally unethical. Like if they don't want their PAP, that's their choice. And it's the same thing here. We have to divorce. We can't say, well, we need to keep some type of cervical cancer screening because women need to come in. What we need to do is a better ability to engage patients. Frankly, I think in the new world with social media, texting, email, you're actually able to do some very important push technology to get women to come in for their routine testing. So we really need to just think of other ways to engage women. So there's certainly a continued need and for both reproductive health stuff, but also the general health screening that women need to have. And just some considerations for implementation. This is from HPV Focal, where, as I said, we've over 20,000 HPV screens, and we've talked to a lot of women. So women are very concerned about the extended intervals. So one of the things I hope when you're talking about extended intervals and later start dates, you can understand the reason why we have the extended interval is actually because of the improved sensitivity. Lori Smith, who's been the program manager for HPV Focal and has talked to a lot of women over the years, has a great line. She says, now, PAP screening started out in about the 1950s and 60s. Do you have any appliances in your house from the 1950s or 60s? And people paused, and she said, yeah, no, that doesn't mean that fridge that your mom has in the basement that makes a lot of noise and you can't, open the lever. It doesn't mean it doesn't still keep food cold. But do you want that fridge? Or do you want the fridge that's temperature controlled and can do, it's the same thing. We're not saying PAPs aren't functional, haven't done a great job, but technology's moved along in virtually every other field. So the same way you don't have to defrost your fridge every 6 months, we don't have to screen you as frequently because it's a better test. So that's I think a very helpful. Lori's done a lot of this, and she came up with that one. I was like, that's the one. A new test. So you alluded to new tests, guinea pigs, trying new things. And I think it's fair to say that the Hans Kruger won the Nobel Prize for this. So for finding HPV. So, it's, I think, pretty legit crew would be my suggestion. Certainly the HPV transmission is an STI. I've been a doc working in STIs for years, and I won't go into it at length here, but I think one of the things I'm very careful about is doing exactly what Anjali talked about, being proactive. Why are we getting this test? We're not getting it for STI diagnosis. We're getting it for cervical cancer prevention, so we're going to work forward with that. In general, my overall advice is don't get trapped into what I call STI CSI. I don't know where you got it. I don't know who gave it to you. I don't know if you gave it to your partner gave it to you. I don't know if you got it. And you know what? I actually can't tell you. To be truly honest, what I can tell you is this is here, and let's move forward and we can act on it. But I can't tell you if you've had it since that one night in college, or if this was something your partner has had for a long time, or if you just had a low copy rate and now we detected it. Like, I don't know. And it's actually not fruitful to try to spend a lot of time trying to sort of figure that out. So that I think that's a rabbit hole that just is not productive. What do I tell my partner? Usually partners, if you've been sexually active, already have it. So it's a sort of an ongoing conversation. You can talk actually about vaccination. You can talk about some of the issues around recurrence, but that's a sort of longer conversation. And those are the few of the questions we've logged. And then healthcare practitioners, the practitioners are also worried about the extended interval, as I mentioned, the time it takes to educate and inform, not having, because it's such a dynamic field, sometimes there's so many things a generalist practitioner has to know that it's hard to keep at the forefront of everything. And whereas if a patient is totally obsessed on one topic, they can drill down. So that's one of the things. So we can actually work to make sure folks are really well prepared. Billing and how you bill for it, not knowing how to counsel women with positive results, where did I get this, when did I get it? So those are things we've been able to help practitioners with, and the implications of positive results. And like I said, we're doing this test for cervical cancer. We can actually prevent cervical cancer, so that's why we're doing it. And it actually, if you have an anticipatory sort of proactive lens to why you're doing this, it's actually very helpful for women. And it's our job is to really frame this as what it is, which is actually, we can actually prevent a cancer that's very exciting and positive, and we're gonna manage this and actually prevent this from progressing any further. So I think with that, I will just say that we did have a central line, so we're working with BCCA to keep that up and to think about how to educate your patients prior so that they have a bit of knowledge when they come in. So I think just recognizing the time, I'm going to leave it at that. So I hope that was helpful.
Any questions for Dr. Ogilvie?
I'm going backwards on this. We have students who come that have had HPV 9 at a physician's office come, and we only actually sell at the moment HPV 4, like the Gardasil 4. And they want to go that direction because it's 144 and not 190, and they're going to go back home and get the Gardasil 9. Is that okay?
So this is where you're sort of getting in, we're supposed to declare when we go off-label recommendations, and Bonnie's here. So my thought on, my answer to this, get the vaccine in their arm. So if that $50 is going to make a difference to them, there's no, the vaccine dynamics are quite similar. So there's no sort of interaction harm. And in fact, Merck did a trial where they revaccinated a whole bunch of girls who had quadrivalent to non-valent. So there's not any safety issues with it. I mean, my druthers would be, yeah, if you've started the 9, finish it. But I get $50, particularly for a student, can be a rate limiting step. I want the vaccine in their arm. So if this is what I need to do to get this vaccine in their arm, give them the quadrivalent and the non-valent. What you can't guarantee are what the sort of ongoing longevity of those extra 5 types are going to be. You just can't guarantee that for them.
But you were talking about how they were going to give one potentially, and then X number of years give another.
Yeah.
So that's the question mark, because these are students who think read and whatever. So their question is, well, if I got one and I get this, and then if I get the last, then...
So let me just be clear, the data I'm giving you guys is kind of the forefront stuff. Right now in this province, 2-dose is only recommended for people under the age of 15. So your immune response once you hit puberty is so much lower. That's why we need to do a randomized trial for it. Yes, that's where it's going. Look, I gave my son 2 doses, even though it's not licensed for boys for 2 doses, way prior to it being licensed for boys, because I knew the science, I was comfortable with it. But that's not what the policy is. So I think you have to be really careful in those situations to also offer people what is the sort of standard expected policy. So, and certainly I think from my vantage, really at 15, 16, you do see this precipitous decline in terms of their responses. So we do have to really be, when we talk about reduced dosing, it's largely in the under 14 crew.
So it's after 25 is one
Press
dose
your-
enough.
No, you press your things. Okay, I'm here.
After 25 is one dose, regardless if it is quadro or higher one. Is it enough one, or do you still need boosters 3 times?
So the current schedule, the current recommended schedule is 3 doses so our school-based program would be between 9 and 13. But if you are going to start a series at 25, no, they need 3 doses.
Thank
you.
Yeah.
In terms of the children not come, or the adolescents not coming back for their scheduled doses, so have there been studies that show that 0, 6, and 10, and like what is effective, and when do you have to repeat the series? When
So the policy in BC is just to restart the series wherever you are. So that's the policy in British Columbia. So if you've had 2 doses and you're coming back for the third, give that third one. Yes, there is actual data, but that's not so I want to, again, I'm going to separate you guys as the sort of peer leaders. There's the research and then there's the policy. The research absolutely says that 2 doses, a 0-6 schedule is very effective. And in fact, 0-12 might even be more effective. So that's a very exciting opportunity that we're looking at. But right now, the policy in BC, short of the school-based program, which you got, short of the school, you're giving 3 doses, and you are giving them, and if they are delayed, you just restart the series. You just restart the series where you left off. You don't start all 3 again. You just restart with that
And does that 2 doses extend to the 9-valent as well? Because it right?
So very good question about the 9. We are expecting to hear from Merck about the 9-valent 2-dose. What I did hear at the recent conference I was at was the guy who's the lead for the 9-valent study said we don't expect any surprises for 2-dose. What I anticipate that means is 2 doses in 9 for the 9-valent is going to be similar to the 2 doses for quadrivalent. Don't look at Bonnie, she won't give an answer, but that's what I suspect.
And it's safe in breastfeeding women, it's just not pregnant women we want.
Yeah, I can't remember if it's actually approved. It's not approved, no.
No, it's
So you
not
should just
approved in
wait till they've
breastfeeding.
weaned and then, okay.
Yeah, to finish feeding.
But it doesn't establish latency, so what would be the big problem in pregnancy? I know it hasn't been
There's
studied.
really no problem.
There's no problem.
There's no problem.
Like
Even
again,
in pregnant.
policy, science, right? So, but the policy is,
And public image.
Okay, well, any WebEx? Not that has been yet, but.
They're not there.
No, we have people there. Hi, Webex, people from Webex. Do you have any question? No. Okay. Thank you.
Okay, well, thank you. Well, I'd like to thank Dr. Ogilvie and the rest of our speakers. I think it's been a really interesting morning. I certainly have learned an incredible amount. One thing, $50 million of BC taxpayers goes into HPV related diseases. And I learned that HPV can be under the fingernails. So I'm thinking that might be a way we can get people to vaccinate their kids, right? Oh, you can get it from holding hands. I don't know if that's true or not, but it sounds a little better. So we've got such a way to go, though, don't we? That the uptake of this vaccine is still way too low, and certainly the BC Pediatrics Society is strongly a proponent of a universal program for boys as well. We all need to be champions of vaccination, and this vaccine in particular because of its controversy, and the number needed to treat with this vaccine is better, but it's more important than meningococcal vaccine, for example. Your child, your patient's far more likely to run into serious grief from HPV, from meningococcal disease. Yet when our kids go off to college, we quite good about giving them every meningococcal vaccine there is, but we forget about HPV. Certainly my daughter got the HPV vaccine when she went off to college. But my son, well, that's another story, but I'm still working on him. But so anyway, I'm going to quote Anjali again. We need to be champions. We need to be a team. We need to be verbal. Every healthcare opportunity is an opportunity to discuss vaccination, and I thought her point of talking to the mom, talking to the sister, was a really good one, because we aren't seeing these boys that often in our practices. Be confident and be visible. So thank you all so much for coming, and to our speakers.